Start the broadcast, thank you.
Good morning, everyone. Welcome to the meeting today, September the 20th. Before we start our meeting, in the light of the last week's sad news, I'd like to have a minute's silence for Her late Majesty. And also, we've lost a member of this committee over the last month or so, Councillor Eddie Cubley. So can we stand for a minute's silence, please? Thank you, everybody. So moving on, we'll now start the meeting. We have a lot of visitors with us this morning, and I'm going to introduce them all in 1 second. But could we just check that everybody's happy with the minutes of the last meeting, please? Which was held on July the 26th. So it's for those people who can remember what happened on July the 26th, I think. Everybody all right with the minutes? No problems? Right, thank you. Could we have apologies for absence, please?
Yeah, so we've had apologies from Councillor David Martin with Councillor Francis Perdue who ran substituting for other reasons. Councillor Maggie McGrath, for apologies for other reasons, with Councillor Errol Henry substituting. Apologies from Councillor Steve Carr for other reasons. And Councillor John O'Lees filling the vacant seat on the committee as well.
Thank you. Thank you for those people who are standing in for others on this committee. May we have declarations of interest, please, by members and officers? Disclosable pecuniary interests, anyone? Private interests, I would just like to declare that my daughter works for the National Health Service, so I would register that. Anyone else? Councillor Eddie.
My husband's a community staff nurse and used to work for Sherwood Forest Hospital Trust.
So that's all recorded. Right. So good morning, everyone. We have EMAS this morning and we have NUH, and we have two for the price of one because they're all in together, because I feel that we're going to be looking at the winter pressures, which from what I understand have already started, yet we're not in winter yet. I think it's of great concern to NUH, to EMAS and to ourselves. So everybody's here together because then we all know what we're talking about. And I'm going to let you introduce yourselves. So where should we start? Let's start on the bottom here. Good morning.
Morning, I'm Dave Briggs. I'm the Medical Director for the ICB.
Thank you.
Morning, I'm Caroline Nolan, System Delivery Director for Urgent Care for the ICB.
Morning, I'm Lucy Dadge. I'm Director of Integration for the ICB.
And we know Sarah. We've got Sarah here from Health Watch. And good morning, gentlemen and ladies over there. Would you like to just introduce yourselves?
Good morning, Annette Mackenzie, Head of Ops for Nottingham South.
Good morning, I'm Bill Kelly, Head of Ops for North.
Good morning, I'm Greg Cox, I'm the Divisional Director for Nottinghamshire.
Thank you.
Thank you.
Welcome to you all. Right, who is going to start us off this morning? Is it you, Lucy?
It is, yes. Myself and Caroline and Melanie are just going to take you through our presentation and you've had the paper. So if
Right,
that's okay,
thank
thank
you.
you. So thank you. If you could put the first slide, that would be great. Thank you. So nationally and obviously within the Nottingham and Nottinghamshire system, there is already significant pressure on urgent and emergency care services. And to respond to the increasing demand, we need to work to eradicate or reduce delays in moving our patients from one point of care to another. For example, from home into an ambulance, from an ambulance into the emergency department, from the emergency department into the right ward setting for their care needs, and then out of hospital, preferably back to preferred place of residence. And if we don't get these pathways streamlined, our residents won't achieve their best outcomes. So we need to focus all of our collective efforts every bit as much on supporting and enabling community and social care settings to flourish as we do on improving flow through hospital settings. And today what we're going to be discussing will apply equally to Sherwood Forest hospitals as well as to NUH. We must work in partnerships of health and care professionals, but also with our residents and families to prevent hospital admissions and attendances wherever best for the patient, and to also to ensure that our residents receive the right support to be discharged as promptly as possible. We must design our services to work with our patients and families rather than just focus on what parts of our care system can do to them or for them. And there is considerable work underway, which Caroline will take you through, to transform all of our care processes, including expediting hospital assessment, diagnosis and treatment, and standardising discharge processes. Again, so that people who require further support are able to receive that and move into their normal place of residence as promptly as possible. We do already understand that winter 2022 may be a winter like none other we've experienced before, and this will be due to the conflation of factors relating to the COVID-19 pandemic, as well as the broader socio-economic system. So to assist with our planning for winter 2022, we've sought advice and guidance from the Nottingham Expert Advisory Panel, which was convened by Nottingham Trent University, who considered the individual and combined impact on and risks to health and care services. So you can move to the next slide, please. So just a bit of evidence from the Nottingham Advisory Panel suggests that the Southern Hemisphere winter, from the Southern Hemisphere winter, suggests that we should anticipate an early and high impact flu season that falls away rapidly. As you'll know, there's a lot of work underway to address our elective waiting times backlogs and to simultaneously ensure that we can meet the anticipated winter emergency demand. And we have also, of course, got to have robust and resilient mental health services that help our residents manage their emotional well-being in the face of broader social challenges, avoiding crisis wherever possible, but also getting access to the right mental health services in a timely manner when they require them. We do need to focus on effective recovery and reablement, using the broadest asset base that we can, well beyond traditional health services. And we have to continue to recognise the relationship between physical and mental health, focusing on working with residents to identify the barriers and challenges that they face to living independently. And this will mean linking factors like welfare benefits and housing issues, travel and transport, medication management, and also access to activities outside of traditional mental health services. We know that for some people, continuing concerns about safety are persisting even after lockdown restrictions have ended, and this can cause people to disengage from work and formal and informal support networks. And there is some evidence that some older people who have been sheltering are reluctant to engage because of fear of COVID-19 and or a reluctance to put pressure on what they perceive to be a stretched services. And finally, in terms of our intelligence, we must recognise that our health and care workforce are vulnerable to financial and psychological strain, which could compound pre-existing challenges with recruitment and retention. Next slide, please. So, lastly, in terms of our insights, we know that across the county there will be different issues facing our residents based on our detailed understanding of the population health and wellbeing needs. Those with pre-existing those areas with a pre-existing high proportion of people on low incomes working in the informal economy and with lower educational achievement levels are likely to suffer the greatest deterioration in their health outcomes. So we have to work together harder to ensure that those who tend to have the most barriers to accessing health and care can do so equitably. We know that concerns regarding the rising cost of living and food, fuel and energy affordability affect a substantial proportion of our population. And if we don't work to address these, we could see short and long-term health impacts, such as increased respiratory infections, later stage disease identification if healthcare appointments can't be accessed due to travel costs, general illnesses arising from poorer nutrition, and emotional distress leading to mental health issues. And again, we must recognise that the same things will impact on the general public, will impact on our workforce. So I'm going to hand over to Caroline, who's going to take you through some of the specific interventions that we want to put in place to help deliver a sustainable system over winter. Thank you.
Thanks, Lucy. So, as you'd expect, as an integrated care board, we work very hard with all of our system partners, so all of the providers right across Nottingham are part of a system that come together to try and manage urgent care pressures on a daily basis in terms of the flow of demand across our system. So we are a system that works in a very connected and joined up way to ensure that at any one point we understand where our demand pressures are, and that together we're coming up with mutual aid solutions to ensure that we support patients who are trying to access care right across a pathway. So that includes primary care, it includes ambulance services, it includes all our community nurse services that are out in people's homes every day, and it obviously includes the hospitals that make up Nottingham, so NUH, Sherwood Forest and Bassett Law as well. So we work in a very connected way to ensure that flows work in the best way possible. So there's a team that works on that each and every day. We have calls each and every day to make sure our providers are working to the optimum to make sure we're keeping patient safety, reducing harm each and every day. As you'd expect, that's kind of the operational day-to-day management that we do, but we've also got an eye to the future, and we also look at the transformation agenda. And we've got a very large transformation programme of work that I'm going to talk to you briefly about in terms of what we do to try and keep people at home, to keep people attending our ED departments appropriately, but also using the services that exist in the community that are probably sometimes more relevant and appropriate for them. So I'm going to talk to you a bit about what we're doing in the ED admission reduction space, a little bit about how we're working with our hospitals to support flow through them, to keep patients safe, and a little bit about how we optimise discharge pathways too. So the first bit here is focusing on 4 areas. So the first one that's a really important project, something that I've been working hard with Greg and team on for a number of years, is the non-conveyance of ambulances to hospital. We know that we can keep patients safe in the community through good hear and treat services where the ambulance intervene at the point of the call and offer safe alternatives to an ambulance being conveyed. We also know that when ambulance crews visit patients at home, they can often put a package of care and support in place that enables that patient to be seen in their own home and treated, or in their care home, and maintained their care there quite safely. So we've done well in that in Nottingham. I think we're a high performer in that area. The Nottingham team have worked really well with our community providers and social care on initiatives like, how we handle patients who've fallen to keep as many people as possible at home. Another area we've focused on in the ED admission prevention space is urgent community response. So we've got a very skilled workforce in both City Care community providers and Notts Healthcare community provider, where there's very skilled advanced nurse practitioners, clinical practitioners, community nurses, supporting people in their own homes, and we've invested quite heavily in that service. So now we get a huge number of people with a 2-hour community response, so may move into a crisis situation and they get a community nurse or AMP out to their home within 2 hours who can set up a care package that keeps them safe at home. So that's another development we worked hard on. Virtual wards is something that's been around a while but is definitely getting significant investment this year, and something we're really excited about developing further in Nottingham. So virtual wards enable us to step people down quicker out of hospital, but also step people up to keep them in their own homes. So we're working hard with our hospital colleagues, consultants, and community services to provide as much care as possible in virtual wards. And there's some new initiatives starting end of this month that are going to really help in that space too. And then the final one in ED and admission prevention is enhanced health in care homes. So there's a lot of work going on with each and every one of our care homes to support both multidisciplinary training, how to cope in the event of falls, how to cope with deteriorating patients, and how to fulfil people's wishes, if they are, to remain in their care home at the end of their lives. So a whole agenda of work that we're focusing on there as well. If I could have the next slide, please. So thank you. So the next area I wanted to just focus a little bit on is about ED flow. So all of our acute hospitals are obviously under significant pressure, both from the emergency pathways that I'm talking to you about, but also from elective pathways and the pressure and catch-up of the post-COVID era. So we're working hard in that space to optimise the use of every bit of capacity we've got. That includes our workforce, our beds, and our outpatient pathways, our assessment areas. So we've got 2 key pieces of work going on in that area, one of which is trying to streamline the front door services so they operate in a very integrated way. We've got primary care and urgent care services at the front doors of our acute hospitals, and we just want to make sure that we're optimising the flows there, that we're taking as many people through those minor and primary care pathways without them needing to progress further into the hospital. I've mentioned ambulance before. I'm in danger of stealing Greg's thunder with some of this, but we are working on pre-handover. We don't want to see, and we do well as a system in Nottingham when we compare ourselves to other areas. We're not resting on our laurels there, but we recognise that it's really important that we get people off the back of ambulances very quickly when they arrive at hospital. We've got a target of 15 minutes. We do very well against that target. We do sometimes get some longer delays, but we work hard to try and prevent those happening, because we know that ambulances need to be released quickly so they can respond to those the next call that needs them, which may be somebody in the community who's got no eyes on them. So we work hard in that space to do that, and it's pleasing to see we've been able to agree with the ambulance service and all 3 of our acute trusts further improvement trajectories in that area as well. The final area that kind of helps system flow and system response is timely discharge, and this has been a major challenge to us as a system. We've got increasing demand, as I'm sure you're aware, for both home care services, community services. We've got increased acuity with patients being needing more care as they're leaving hospital. So we are working to try and address those demands. The 100-Day Challenge is a specific initiative that's focusing on really looking at sort of 10 top initiatives that have got a good evidence base to show how you can further improve discharge. So one of the areas we're focusing on there is making, in our acute trusts, having a community hub that involves our social care people, our community trusts and our care home links, so as we can really optimise how we move patients through the discharge pathway without delay. We know that it's not good to keep people who are medically safe in hospital, so we're trying really hard to get people out as soon as possible. We've got more work to do there, but we have a very clear plan, and we've invested heavily in that of late to try and get the right amount of capacity in our Pathway 1 pathways. Pathway 1 pathways are pathways that get people home. So we're not keen on getting people into care homes. We're really trying to optimise the number of people who can actually get home and have care in their own home. So we've got good engagement to that as well. We've been looking throughout COVID, but with renewed rigour really at the potential demand and capacity that we expect to see this winter. So we've done some good modelling to look at what would a standard winter look like, and also what might the winter of 22-23 look like if we get an increase in COVID and an increase in flu at the same time. What will that do to our resources? Will we have enough resources to cope with that? So we've modelled that. We've put significant mitigation plans in place to ensure we've got enough acute beds, that we've got enough community capacity, that we're working with primary care well. And then the final bit of that is that we're working with our communities well. So as they understand the significant pressure that the health service and social care are together experiencing. So there's a campaign around Help Us to Help You, and that's all about how to access health services appropriately, how to support elderly relatives, friends, perhaps in a volunteering way, to enable them to get home from hospital quicker. So that's kind of the core elements of our plan for winter. Thank you.
Thank you very much. Melanie, would you like to say anything at this point?
Yes, and I think Lucy's asking me to comment on community resilience, so I can make some comments from a county council perspective, Sue, and then just talk a little bit about some of the things that elected representatives or committee might support us with. So from a county council point of view, we are expecting this winter to be particularly difficult for our residents, and particularly those that draw upon care and support. So as you've heard from Caroline and Lucy, we are seeing people being at home with increasing care needs because of the wait to have elective procedures. So that means we're having to provide more social care to that person than we normally would. Additionally, we have workforce pressures which have been exacerbated by absences for COVID. So although we're providing more home care and more residential care than we did this time last year, we're struggling to do so because of the workforce challenges, so we've got the extra pressure. And we know that people who draw upon care and support, who have vulnerable children or have disabilities, are also going to be more adversely impacted by the cost of living pressures, particularly utility prices. So we are expecting this winter to be difficult. So as a county council, my role has been to work on the initiatives with the Integrated Care Board, and Caroline's touched upon social care and our points of relation, but equally supporting the system, so particularly supporting the NHS and the primary care networks to start thinking about community resilience, because more than ever we're going to need to support people that live in our areas around the county to be as resilient as possible. So those sorts of things would be, fuel to consider. How do you support people to access additional transport schemes so they can maintain their appointments? How can they access any community facilities that might help, such as the food banks or services or support? I'd also be looking for you to encourage, we'll provide public health here at the council, so how do we encourage vaccine uptake, supporting people to access that type of services? And incidentally, through the public health grant, we're investing in resilience, particularly for financial resilience through the winter. So that's going to be a particular importance for us. And then I suppose ensuring that anybody you come across, you encourage to be fit and well. And then I guess there's an opportunity as a committee to be considering, are there things as a health and care system that we need to consider that you haven't heard today that you'd expect to see? So an opportunity for you to raise some comments. But I think that's all. Councillor Saddington, I'd like to comment there.
Thank you, Melanie. I'm going to turn to the ambulance service in a minute, but I just have one or two concerns I'd just like to raise at this point. It was drawn to my attention last week that COVID has become prevalent at City Hospital. Is that correct? That it's quite a lot of cases, including staff, which would be my next question as to how you're going to cope with this. Is it correct?
I haven't looked at our occupancy data today. I am not aware of a particular issue at City. There is background COVID in the community. We will continue to have patients in hospital beds suffering from COVID. the good news is that those patients, because of the benefits of the vaccine programme, don't tend to get so severely ill. So these can normally be cared for on general beds, obviously managing infection prevention and control, and there's much less pressure on intensive care unit beds. But at the moment, I mean, COVID is there, it has continued to be there at a background level. I'm not aware of a particular exacerbation or spike in infections in patients or workforce, but it is something we can look into.
It was staff particularly that I was told had got COVID at City. So I did just wonder how that was going to affect everybody. Caroline, you mentioned that you're hoping to keep people out of the emergency department. But am I not correct that people will present themselves at the emergency department? So my question to you is really, what are you going to do with them? Their instinct is to get somebody to take them to the emergency department. And where do you go from there? Because you've clearly got plans made for what would be the winter you're expecting. But everyone is saying what a difficult winter it's going to be with flu and COVID. So I think the whole of the committee would be aware of that. So here you are. Your elective surgery probably won't go to plan because you will have COVID and flu patients, and you will have people presenting themselves at the emergency department, and then we get it on television that everything's going wrong, people are being turned away, etc., etc. So how are you going to... You've got it written down how you want to operate it, but with the best will in the world, your plan may be upskittled quite early, and I'm just wondering how you will address that, because I'm sure if we're all honest, we're expecting something quite bad.
Do you want me to kick
Yes,
this off?
anybody.
In my previous role, I worked in Leicester Royal Infirmary ED as a clinician in there. So the key to managing walk-in demand, so people who choose to take themselves to hospital, is effective initial triage. So in the hospitals, we have a process where we look at how we assess the severity of an illness, and then have separate areas in the department or adjacent departments to deal with that. So if you come in and your story sounds quite serious, you'll go to a more intensive setting than if it's something that can be managed by a service with less intense staffing and services. So that is called streaming, and what we try to do is get the right patients and their families and carers to the right service as quickly as possible. And if we do that, and when that's done correctly, it really reduces the burden on the acute services and allows people to be seen in a much more effective way. So what we really need to pull out is those who are most ill most quickly, so they can go to a very intense setting and get that sorted out with all the appropriate services. But if it's a less serious, still important, it can go to a less intensive setting where you can actually get through, you can actually see more patients and citizens more quickly with less complicated services. So that triage process is really critical. It's an area of work that we've spent a lot of time with NUH and Sherwood Forest, who's one of the national exemplars, about how we, for Notts and Nottingham, get that process absolutely right. And one of the great things I think that we're doing as a system is something called same-day emergency services, SDEG. And what that does is if you've got a service where a condition which requires urgent investigation, you can get all that done in the same day, so you don't have to stay in overnight. And it's one of the areas that in Notts and Nottinghamshire we're really focused on. So if you present with an urgent condition that requires urgent diagnosis, we can get that turned around the same day. And for me, one of the key things to delivering for patients who admit is pick the most serious people out who require really intensive setting, and for those who can be and would like to be managed in a less intensive setting, get their services skilled up to deal with those patients quickly. And that includes having access to primary care for conditions that can be dealt with that workforce. And that's one of the great pieces of work I think we're really making progress on, and certainly learning from Sherwood Forest, who, as I say, is a national exemplar in this process.
Okay, thank you. Lucy, did you want to come back on that?
Yes, just to give you an assurance that we are equally focusing on managing our elective backlogs and improving our elective backlogs, because as Melanie highlighted, if we cannot treat people's elective illnesses, you know, their quality of life, their capacity to live independently will deteriorate. So we have a very sort of detailed set of models that predict what we're expecting around emergency demand and the capacity that we need to protect to ensure that we deliver the planned care that we can to really start to eat into those elective backlogs. So we do manage that. You know, clearly that model has a few tolerances in it, but based on kind of what we're expecting, which was the help, you know, when we have a lot of population health data, we can continue to manage that balance. But it is really important that we focus equally on both.
Right, I'm going to pass over to other members now, but I think summarising what you're saying is we who mix in the community with our parish councils and our groups and the community in general, your message to us, how we can help, is to remind people to have vaccinations when they're offered them, to keep fit where they can, and to eat well where they can, and to be ever mindful when they're in the community that there are things around and to beware. Is that your message that you'd like this committee to take back? Right. Can we all do that, committee? Right, let's turn to Councillor Lee.
Chairman, thank you very much. Where do I start? So, give a little bit of brief information about me so you'll know where I'm coming from. Injured serviceman, lost my leg in Afghanistan, 2 young children. You are being let down by the doctor's surgeries. That's the truth and answer. You are being used as an overflow to doctor's surgeries. People can't get doctor's appointments, so they go into A&E. That's a simple fact of it. I'm telling you that for a fact because it's happened to me about 20 times in the last year where you ring up doctor's surgery going, I need an appointment for this. Oh, yeah, go to A&E. I don't think it's urgent enough to go to A&E. It's this. Oh, yes, you can't get an appointment for 3 weeks, 4 weeks. Or you can only get a telephone call, or you can only get this and only get that. And people want to see somebody. With the mental health situation that we've got at the moment, with COVID and everything else, people just want that assurance that they're not going to drop dead tomorrow. And a lot of it is go to A&E, and the emergency service number doesn't work. It does not work. You ring them up, and I'm somewhat medical trained. I was in the military. I'm a field medic in the army, so I've got some medical training. And you're ringing up explaining something, and they're just ticking boxes, and you might tick a box that goes, right, you need an ambulance. It's happened to us twice with my little boy, and we know it's not, I know it's not an emergency to need an ambulance, but you've been advised to call an ambulance and go to A&E, when actually all you need is a doctor just to see your child or to see you, just to say this is the situation, you need some medication or you need this, but you're being advised to go to A&E. What I believe we're missing in the service, and it has been rolled out in Manchester in the past, I don't think it works anymore, I don't think they have it, is an out of hours or an in hours doctor's surgery where you can go in, you can, but no, you say we haven't because it doesn't work, where you can literally, if you go to see a doctor, wait for 3-4 hours and see a doctor. If I want to see a doctor now and I ring up my doctor's surgery, I'm not going to be told about an out of hours doctors. I'm going to be told I have to wait for 3 weeks to see a doctor and they'll ring me. I can't get an appointment, they'll ring me. Even though I know and the doctor knows that I'm going to need an appointment because of my complex needs. But they'll ring me, waste half an hour speaking to me on the phone to then tell me to go down and have an appointment when I could have just had an appointment. And that's the problem. You've got wasting time because they're being told to do it in a certain way to keep people at doctor surgeries because of COVID, but they are wasting time with the people that we need to see. Then people are getting fed up and going to A&E, yet again, wasting your time and wasting emergency time that could be used for emergency service. And because people aren't being told what services are available, if they are available, I disagree. But in Newark, they're not available. In some areas of Sherwood, they're not available. In Collingham, they're not available. In Connington, they're not available. If you do get to see a doctor out of hours, it's very rare. I think my little girl is 7, and we've managed to see the emergency out of hours doctor twice in 7 years. Most of the time, we have to go down to A&E. So the service isn't working because, in my opinion, you're being let down by doctor surgeons not doing what they're supposed to be doing. And it might be staffing levels, it might be other issues, but they need to be addressed. And me and Sue know in particular, in some areas, that more needs to be done and it's not being done. I get complaints regularly from residents in my area, Balderton North and Connington, saying they cannot get doctors' surgeries, they can't get appointments, so they go into A&E. And I know I've mentioned that a few times, but that, in my opinion, that's the biggest issue.
Would one of you like to come back on that one?
So shall I start? So thank you. I think your reflections around the importance of primary care in terms of urgent emergency care is really valid. So it's got what we call a gearing effect, I'm sure. In other words, if you've got a primary care setting that's not working, the impact on secondary care can be quite large. So if you look at the number of citizens and residents that attend their GP every day for urgent care, it's huge amounts. It doesn't take much in terms of reduced access to have a significant impact on our secondary care service, and we accept that. We also accept that it's one of our highest priorities, access to primary care, not only for general practice, but in the coming months for dental access as well. And there's a number of initiatives that have been spearheaded, particularly with primary care networks, around different staffing models and different ways in which people can access services. And the experience across Nottingham and Nottinghamshire is varied. So there's some areas have managed better access than others, but overall we hear the population and we want better access to general practice because we think it's one of the crucial ways in which we can improve health outcomes as well as improve the experience for our citizens. Have we got it right? Well, I think we're working on it. There will always be examples at the moment of poor access, and if there's any particular issues around individual surgeries, we'll happily take that offline and look at that with you and for you. But I can confirm it is one of our high priorities with a number of different initiatives to try and address it. The service itself is under huge amounts of pressure for the same reasons as the acute. So there's workforce challenges, there's issues around backlogs of patients. Backlog's such a horrible word, isn't it? There's an issue with a lot of people who need healthcare addressing in a more planned way, who haven't had the opportunity to do that yet, which we need to resolve. So what we're asking of general practice at the moment, in terms of ensuring people with long-term conditions are getting those sorted, making sure that we're improving access, and it's quite a challenge. So absolutely, we agree with you. We need to improve it. The service knows it needs to improve it, and we've got a number of different things that are going live soon to try and do that around how practices work together, around the staffing models in general practice, and some clear metrics or measurables for what the experience is like now on a regular basis, how that's improving over time. So I think, to answer your question directly, I would be hope that when we come back in a year's time looking at primary care access, that we've seen some improvement. Because the reason you say the impact on your health and well-being of not being able to access their essential services is dramatic, isn't it?
You've just mentioned a year's time. I was thinking of a couple of months.
Okay. So there's some initiatives I think we can report back on that are starting to complete. But the actual how do we increase the capacity in general practice to meet everybody's need is an ongoing journey which we're committed to following.
Lucy knows we've already looked at primary care. We've got so far, and we need to return to it. And Noel has just drawn my attention. We're returning to this in January. So no doubt we'll have you back again, and you'll be able to look at it. I've got Councillor Welsh next, please.
Hiya. Telling me to turn my mic on. It's on. Where to start, really? I'm going to start from perhaps where I think the beginning should be. I looked through this yellow document and I was pleased that it did come up on the presentation. You did speak about it, Lucy, and that is with regards to staff welfare working in our hospitals and in our care system. We've gone through a high pressure time for all of those staff throughout a pandemic. A lot, no doubt, are still very tired and emotionally exhausted about some of the things and some of the things that we've been through, and we're now facing a winter crisis that people are talking about is going to be one of the worst in the whole of our history. And I was just wanted some clarity and some information of what fundamental things you are putting in place for your staff at NUH. without ignoring, obviously, the recent inspection that said there were some issues with regards to how some staff were being treated within NUH. I feel as a committee we should have some real assurances that the staff that are working in our hospitals to take care and protect our most vulnerable people and in our care work are going to receive the support they need, and that may include some emotional and mental health support. It also may include some direction with regards to, we've talked about the cost of living crisis. I went to a food bank recently and there was 2 health workers in there at a food bank. So there's an issue. And I just want some reassurances that your staff is also going to be a top priority, because we won't be able to be delivering any of what you're talking about if your staff, you'll know this, isn't able to deliver the work and go to work. So that's my first point. My second point is, it's a procedural question that I want to ask with regards to ambulances and A&E. But she said something quite interesting, which goes against my 2 latest experiences of what happened with regards to A&E in the ambulance service. So I would like some clarification on procedural. The first thing is, phoned an ambulance for my father. He has a life-limiting condition. Was told he'd have to wait 5 to 6 hours for an ambulance, because at that stage he was still breathing. It got to the point where I thought it was difficult for him, and phoned them back up, and they said the problem is if you take him in, he's going to be longer in A&E, sitting there in that room, than if he goes in by ambulance, he'll get seen quicker. That's what I was told on the phone. So I had a choice of sitting there seeing my father struggling to breathe, knowing that he's going to have to be on his own in A&E, because you wouldn't let anybody in with me last time with him, even though he gets very confused, unable to get a drink from anywhere, because there's nowhere to get a drink unless you walk right down the corridor. And A&E tell you, the staff do say, if you leave that room and they call out your name, then you go to the bottom of the queue again. So I was faced with that choice. So if that is being said, I'd like some clarity on that if you go in an ambulance, do you get seen quick? That's my first question. The second question with regards to procedure is, when I went to pick my dad up, he'd gone from a separate emergency room. So he wasn't in the main room, he was in another room. It was probably twice the size of this, and it was full of beds, literally next door to each other. I was shocked. It was like something you see on the front page of a newspaper. Bed after bed after bed after bed. There was that much gap between my bed. In the corridor was probably the most frightening thing. A corridor which I counted 22 trolleys, and it wasn't a red or a black day or anything like that, all with 2 members of your staff by each trolley, all with the paperwork waiting hours. So one of the reasons people were phoning up and not getting an ambulance is because they were in a corridor in NUH, and all of those people on that corridor were elderly people, I have to say. Vulnerable, not very well at all, wanting a drink, needing a hospital bed. This is before the winter crisis that we're talking about. This is now, in a corridor on a bed. And I'm really sorry. I find it really difficult when you say, in comparison to everybody else, we get them transferred from ambulance into the hospital, really. 15 minutes. Is that 15 minutes from there into that corridor? Because people are waiting hours in a corridor in our hospitals here in Nottingham. That is the reality. And this is what frustrates me here with this Health Scrutiny Committee. Time after time after time, we just want to know the reality. We want to know really what's going on. Because us going back to our communities, telling people to eat well and have the vaccinations is not going to solve that problem in that corridor. That's the reality of it. It's not going to be able to people to put their heating on during the winter, and it's not going to feed people over the winter either. That's the reality of the winter crisis in our hospitals. We've got staff that are overworked and underpaid, in my opinion, for the most part, without going into it in too much detail. So that's my two, the procedural problem of where do these people go when they go into the emergency room? Where do they go if they're not in this corridor? And what is that issue? And what is the problem? And what is going to happen during this winter? Where are those people that get brought in going to go? And is it a reality? Is it a reality that people are going to be able to have to phone an ambulance, and the ambulance are not going to be able to get those people to hospital? Because if we're already talking about that now, What is going to happen in a few months' time or in a month's time when it starts getting colder? There's my first other things. The other thing that I wanted to ask as well, which I think it would be really important to know, what is the current average waiting time in A&E at the moment? So the people that I've been talking to at the moment, it's about 14, 15, 16 hours. Took someone with a serious life-limiting condition 18 and a half hours to get a bed from the moment that they entered A&E, and they were in a corridor for the most part for that. 18 and a half hours to get a bed, someone with a life-limiting condition. Whether they were well enough to stay in the corridor is by the by. There's something about how we treat people, isn't there, as well, in all of this. And then the other thing that I wanted to talk about is we talk about community resilience, leading a healthy life, you know, making sure you have your vaccinations. The communities that I represent are very resilient. They've gone through a lot in their time, to be quite honest. They're very, very resilient. It's not true for every GP services, but it's like counselling. They can't get a GP appointment and the situation gets worse. But I tell you else what also they're saying to me when I went to a community a support group, recent health support group. You know what they're saying? I'm going to try and keep myself as well as possible because I am scared about going into our local hospitals because I don't know what's going to happen when I get in there. Because of their recent experience. So that's the other bit that I'm worried about, is that people are going to be genuinely not very well, can't necessarily get a GP's appointment, are worried and see other things about not phoning 999, and actually are left vulnerable within their own homes. And I think that's equally as important as a committee, to be going out to tell people that if you need medical help, then you must phone and you must get in touch. Because I think more and more people are leaving things longer and longer and longer, and I think that's having an impact on. And last but not least, with regards to elective, and then I will be quiet for a bit, promise. The elective. There's a big backlog, again, I don't like that word like you do. There's a big backlog with things like colonoscopies, aren't there? And the reason that I say that, I should have had an emergency colonoscopy 6 weeks after I was in hospital 8 months ago, and I've still not got it. And I've got a letter asking me whether I'd gone private yet or not from your hospital. have I had it already done elsewhere, is what the question that I was asked. So we are talking about a winter crisis. We're talking huge backlogs on things like this. We're talking about a cost of living crisis, which you've mentioned. I'm not bringing this up. I'm not going to get thingy about it. A cost of living crisis. People having to choose between eating and heating. Is the reality not the case that a lot of people are going to suffer this winter? And actually, it's going to take more than us lot going out into our communities. It needs something a bit bigger and a bit bolder of a strategy if we're to protect people, our old elderly and vulnerable people in our communities. Is that not the case? Because that's what I see it, and that's how I see it now.
Right, who should we bring in on that? All of you. Yeah, I think you've got a long list of things there. Would the ambulance people just like to comment? I have to agree with Councillor Welsh. It surely is the fact you can't get these people into the hospital that is creating these long waits. And I've had a lot of people tell me that they've waited 8 hours for an ambulance to get them to hospital, and they are seriously ill. So I think this is a very big question, which Michelle has actually raised. Perhaps you'd like to give us some insight into it, please.
Thank you, Chair. I'll certainly try. In response to the councillor's first point around the relative and the advice she received, I can only apologise for that, because that doesn't sound appropriate advice. Certainly, as far as I'm aware, NUH and Sherwood Forest triage processes for receiving any patient, whether they arrive by ambulance or walk in, would be the same. They have a duty of care to ensure that their patients are triaged appropriately. So for one of our EMAS colleagues to have made that advice is incorrect, so I can only apologise for that one. waiting times and handover, it's in our presentation as well, and there are no easy answers and no golden nuggets within what I'm going to respond either now or in the presentation. It is a difficult problem. From an EMAS perspective, there is the issue that we have a regional service, and therefore, unfortunately, we have a responsibility to deliver that service equitably across the region. And that does mean that when other systems are perhaps more pressured than our own here in Nottinghamshire, resources are moved about to respond to that. And that's, as part of a regional service, what we're obliged to do. In terms of that more localised view, in terms of Nottinghamshire, I can say I don't like hiding behind data, and I'm not intending to mask anything by using data. But certainly in our presentation, it's an absolute pure fact that the waiting times in Nottinghamshire hospitals is significantly, and I mean absolutely significantly better than any other hospital in this region, in the East Midlands region. We do have times of pressure. We do have times where there are long waiting times, I agree. I think we're in a very lucky position that both of our acute trusts, all three now, Bassett Law as well, have made a commitment that they will offload their patients, even though that then gives them internal difficulties and you see queuing in corridors. But the clear evidence in our data is that ambulance crews in Nottinghamshire are released far quicker than other hospitals within the East Midlands. So I'm not trying to hide behind any data, and I'm not saying those waiting queues don't happen, they do. All I'm saying is they occur far less in this county than other counties.
Could I ask what that time is then? What's the average? What's the average time? So if it's significantly less than Leicester, and Leicester take 24 hours, but we take 12 hours, there's still a problem, isn't there? So what are those differences? Is what I would say, because someone waiting in a corridor that's been brought in by an ambulance, that's in a corridor for more than half an hour, is obviously surely going to be a bit of a problem. So what are those times? I just want to say as well, I'm not critical of the ambulance service. You are under an enormous amount of pressure. I just want us to talk about the reality, so actually we can speak to the right people about supporting you. This isn't about criticising you. I think you're fabulous, and I fundamentally believe in everything you deliver. What is the reality? I want to know the truth. I want to know what the reality is.
Yeah, sorry. Okay,
come back, yeah.
Thank you, Chair. And again, it is in our presentation, and I apologise for using data, but in direct answer to your question and one of our slides, so it describes the reality that the average daily handover time in Nottinghamshire runs at about 35 to 40 minutes. So the national standard is 30 minutes. So we're in excess of that, but not by a lot. And certainly when you then compare to the average hospital turnarounds in the East Midlands, that's over an hour. So it's not quite double in the rest of the East Midlands what it is at our hospitals, and that's the data that sort of you asked the direct question.
Yeah, I think our problem, and the one of Michelle's, is you're comparing yourself to Leicester or to other authorities. But the question is, I think what we want is the exact information. That obviously is how you make comparisons, how you work against the times that Leicester might take. But at the end of the day, are they the correct times that people should be sitting waiting? I think that's the answer. And what we can do as a committee to try and make it that we won't have these long waiting times. We'd have to be God, I think, to do that. But still, let me bring in Councillor John Wilmot, please.
Yes, thank you, Chairman. Can I make it abundantly clear that the people working in the NHS system do a remarkable job of work without any, there's no question to that, but there are problems. Paragraph 3.4 talks about the health inequalities that exist in Nottinghamshire. It states areas such as Mansfield and Ashfield are similarly at risk from the worsening economic situation because it was already vulnerable due to people on low incomes, working in the informal economy and with lower educational levels. You are correct in identifying this problem. The places like Hucknall suffer from extreme poverty, with many struggling from poor access to GPs. It's one thing identifying the problem, but it is an entirely different thing to allocate resources to where they are most needed. My question is, how is the Integrated Care Board working with partners to allocate resources to areas like Hucknall, Ashfield and Mansfield, where your own statistics say they are most vulnerable? Now, can I say the number of questions that come straight to the fore are, there is briefing your briefing papers suggest that there's vaccine hesitancy. Is there any evidence of vaccine hesitancy among the wider population? You talk about in the paper possible industrial action. I just wondered, is industrial action specifically within the health and care sector a distinct possibility? And then, of course, you've got the NHS England Effective Recovery Plan. Could you tell me what plans are in place to reduce screening and diagnostic testing waiting times, particularly for cancers? Thank you very much.
Who's going to answer that one?
So just on the how are we looking at resources in our neighbourhoods and places that have got the most need. So one of the principles that we've agreed as a health and social care system is that of equality rather than equity. So rather than having equal access, we have equitable access. So if it's harder for you to access services, it's made so you get the same outcomes by looking at how you focus resources. And that's only recently been agreed, and we're using all of our data, population health management data, to look at how we can really make a big difference on that. And one of the areas that we know we've got some of the widest gaps is around respiratory disease, and we're working with a group of specialists in terms of data analysis to look at how we can improve the outcomes for respiratory services by thinking about and delivering with people, how that service works. So when we've got the full answer yet, it's quite a complicated problem, but we recognise it's one that we need to make more progress on. And in terms of how that looks at an ICB board level, as I'm responsible for health inequalities, that is now a significant agenda item on how we're going to progress that going forward. So we've got exact plans, we're working on them. We recognise that doing things the same way we've done before, with the same service delivery model, hasn't narrowed those health inequalities that you've described. And we need to think about how it's done differently, but do it with the input of populations rather than just the services. So there's a whole piece of work to how we make what you've described happen. Have we got it right yet? No. Otherwise, health inequalities wouldn't be widening. Do we need to do more work on it? Absolutely.
Thank you. Anybody else want to?
Yes.
Lucy, did you want to say?
Yes, just a couple of, in response to your question, Councillor Wilmot, about what are we actually doing, just particularly to address things like screening backlogs and diagnostics backlogs. So there is something called the Targeted Lung Health Checks programme, which is a programme that looks at our population that are most vulnerable to lung cancer and makes sure that, starting with primary care, we're actively case finding. So we're using the data that we've got on our GP list to identify people who we will then bring in for screening, and with a view to being able to detect particularly lung cancers earlier, before symptoms present themselves. And that programme is very, very much focused on data that tells us where those patient populations are most likely to be. And we have actually done 2 pilots, and I think you might know that one of them is up in Mansfield as well as in the city. So that's very much focused on case finding, getting in there, supporting people who may be at most risk. Similarly, you mentioned diagnostics, and Councillor Welsh mentioned diagnostics. And yes, we do have not just elective treatment backlogs, we do have elective diagnostics backlogs from COVID, we are looking to build something that are called community diagnostic centres, so actually putting additional diagnostics capacity away from acute hospital sites onto community sites, and Mansfield is one of our principal proposals, so we hope to be rolling that out within the next couple of years. And I think my other comment was just a general one, which is, you know, thank you both actually for your passion that we must get this right. We know it's okay to say that our system is working better than others, but we want our system to work perfectly. We're all here because we feel really strongly that we want that to happen, and I'm accepting that comparative data isn't helpful. Securing the right workforce now and in the future is absolutely critical to that. We can't just look at the health workforce, we have to look at the health workforce, the broader social care workforce. We need to mobilise our voluntary sector. And I think there is something about, we do need to give people sort of this sense of hope that if we can sustain and retain them, we can make this better. Because as I've said, you know, our workforce are our residents as well. So I think that has to be a massive focus. I can't talk for NUH, we don't work for NUH. But we do know that with its new leadership team, there is a real focus on helping the workforce regain that sense of hope and that commitment. And I do think that we will sort of start to see some significant improvements in that regard.
Thank you, Lucy. I just want to make it clear to our visitors, we're not criticising you as a team because you are exemplary. What we are trying to do is to ascertain what we can say to the people who come to us, who say, so-and-so had to wait for an ambulance for 7 hours and they were rolling about on the floor in pain, this sort of thing. And we want to be here to help you, not to criticise you, because you've got, you know, I would be the first to say, you've got an unenviable task this winter. We all know what it's going to be like, and we all think, how on earth is everybody going to cope? And it's not helped by the fact that there's the cost of living crisis as well. So we're not criticising you in any way, shape or form. We're bringing stories to you that we, out in the community, actually hear, and we need an answer to them. But we're not criticising you because you are exemplary, and we just need to all work together. So I don't want you to think that any member's criticising, because we're not, we're just highlighting. Okay, thank you. Councillor Wilmot, did you have a reason to question?
There were just two questions that I just, if anyone's got any answers to. Is there an evidence of vaccine hesitancy, you know, people among the wider population, and is there any possibility of industrial action? Have you heard anything to the contrary or whatever? Thank you.
In terms of vaccine hesitancy, I don't think there's any specific evidence that we have a problem in Nottinghamshire. But obviously, what we need to do is what we did in the peak of the crisis, is to really work with our populations to encourage people to understand the benefits, because it is one of the biggest things that you can do, not just COVID, flu, to keep yourself well over winter. So we're not aware of any particular issue. In terms of industrial action, we don't know. I mean, we work closely through our local resilience forum with our other wider government partners. We can't be sure, but we clearly, as we always would, we will have contingency plans in place should we find ourselves in that situation. So, you know, we don't know specifically, but we are planning for that potential.
Thank you, Lucy. Councillor Henry.
Thank you, Chair. One of the questions I wanted to ask was answered. Councillor Wilmot asked that question and you answered quite well there. It's around the screening of, especially for cancers. And I know one of the cancers I'm thinking about is prostate cancer. And I know that overall death rates of men with prostate cancer has increased from 7% before the pandemic to over 26% now. So I know you talked about elective procedures and how that's going. For me, that is a problem, because if men aren't being diagnosed early enough because of thinking they'll keep away because they know that they can't get anything from a doctor's surgery, like similar to what Councillor Lee was saying, they're not being diagnosed early, And if they are diagnosed, they can't get a procedure at the hospital. So they're therefore living with that disease longer, and therefore death comes quicker. So you talked earlier about the targeted lung health care, and especially for men between 60 and 70. They're more prone to have that, and especially within our community, BME community. I don't know why it is so high, but for black men tend to have prostate cancer more prevalent, and they're the ones dying. There is a group in Nottinghamshire called Friends and Brethren that works with prostate cancer, and the complaint they've had from me to me is that their men aren't been looked at all, and they're dying. So what is it that you're going to be doing about that bit? I know you talk about, we are on the right track, but what track is that? Because they're dying. Men are dying quite a lot. So an increase from 7% to 26% is very, very worrying. So I just need to know what you're doing about it and what's happening in that area. Thank you.
So
Who's going to answer?
So maybe if I start. So I think even before the pandemic, the outcomes of certain groups of our residents wasn't equitable for prostate cancer. I think Councillor Henry, you were alluding to that. And it's a piece of work that the Cancer Alliance is looking at, about how we increase uptake of people with symptoms of prostate cancer early, and how we ensure that the service is responsive to their specific needs. And the outcomes vary quite dramatically according to which ethnic group you come from, with certain groups, I say, not having the same outcomes as others. And it is a piece of work that the Cancer Alliance locally is leading on, in terms of across the East Midlands, how we improve that and what we need to do. The second is how during the COVID epidemic, how cases for surgery were prioritised. And because there are other treatments for prostate cancer other than surgery, the number of people waiting for treatment in terms of prostatic cancer was higher than some of the other cancer treatments. So we are proactively working about how we rapidly reduce that in Notts and Nottinghamshire, and also to regional level. It's one of the, if our colleagues from Cancer here, it's one of the things we're working on the most. And one of the areas that was particularly impacted was the diagnostic, the cystoscopy element of it, and that's a particular area of focus about how we can create so-called cold services where we haven't got any hot, so we can maintain that over the winter period. There has been progress made on this, but there's still work to do, specific work to do on some specific groups of citizens who currently don't get the same outcomes as others. But as I say, there's a programme of work to look at that, engage with groups and look at how we can do that better in Notts and Nottingham, of course, across the wider East Midlands.
Thank you. Or do you want to come back?
Yeah, but thanks very much for that answer. But what will I say to my residents when they ask me a question like that? Why is it that we are experiencing this? We are not getting diagnosed. We can't get the treatment. What do I say? I can't tell them there's a piece of work going on, and they'll soon will get an answer. That's not going to help me at all. We need something else for me to say than just what you've said. Sorry.
Yeah. So we want people who've got symptoms, so low urine tract symptoms, so hesitancy, blood in your urine, or reduced urine flow, to present to their GP so they can have the correct diagnostics done in general practice to be referred on. So there was a concern that people who often find that early symptoms of prostate cancer aren't particularly serious, don't present or present late. We're in for business as usual now. So if you've got urinary symptoms and you're a man and they're persistent, you've gone for a couple of weeks, you should be presented to your doctor for those initial tests. So that is absolutely true, and has continued to be true, that we want people to present so we can do the right investigations and diagnose them early. We do know that certain groups are reluctant to present to their GPs, which is what this particular piece of work is doing, to how do we communicate with individuals and groups of people about the importance of lower urinary tract symptoms in men.
Thank you. Lucy, did you
Probably
want to-
just to add, Councillor Henry, as we discovered, didn't we, with the vaccine programme, that you need to engage with different populations in different ways. We can say our screening programmes are fully up and running, but if people don't find it easy to access those screening programmes, it's no good, is it, to say the programmes are up and running. So I think a little bit, as Dr Briggs said, around GP access, if you have a particular patient group that would welcome a direct intervention with us through our comms, we can come and talk to you actually, because I think it's about understanding. It's all very well saying the services are there, but if you would like to contact us, we do have a range of different comms colleagues, have some really good relationships. You may know them, but if you let us know, we'll come and talk to you about it.
Thank you. Councillor Eddy, Vice Chairman.
Thank you. Just coming from, my husband's a community staff nurse and he's exhausted. I think might be to do with a 2-year-old as well, but in general, the last couple of years have been really exhausting for staff. Whenever we speak to you guys, it's always staffing, retention. What is the morale like for staff? What are we doing to make sure they're ready for what's to come? Because they do such a fantastic job. And it's the pressure on them must be absolutely huge. And if we're looking at winter pressures, is there more that could be done to make it easier for them? And then the second thing was, when we're talking about the route we need to direct people to, is there more, and you're saying we should be doing more in communities, is there more that could be done to direct people to certain services? Because I don't feel that we do that very well. And that's coming from someone who recently used services. I had emergency surgery in 3 days. It was amazing. But I think that was because I followed the route I should have used, which was GP and then emergency surgery. And it was a very quick thing. But is there more that should be done to direct people to those services? So we've got less people waiting for GP appointments or, the 111 service. And I just think there's more that could be done with that. But the staffing and retention, it worries me because I see my husband and he is exhausted, bless him, and he can't be the only one. So I think there must be something that we can do to help them.
Yeah, I can start with a general comment, but I think Caroline might want to talk about, I think it's this thing called, it's how patients flow, and I hate to use words that kind of dehumanise, but how our residents flow through our systems. And I think one of the things that we need to work together, and I say it's not just an NHS thing, it's NHS, it's social care, it's everybody who supports our residents, is to encourage people to use the service. As you quite rightly said, when it works brilliantly, doesn't it? To use the services correctly. So don't call an ambulance if you don't need an ambulance, because every ambulance that goes out to somebody who doesn't need an ambulance can't be used for somebody who doesn't need an ambulance. And you get this sort of, every person that spends too long in an ED probably will then spend a bit too long in a ward and therefore may well be discharged to the community needing more care needs than they might have done. So I think it's I think the two things are interlinked. We have got some quite complex systems which we as a health and care system need to simplify. I think if we could simplify them and people could start to see patients, because as you've rightly said, nobody's doing this because they want to get it wrong. They're doing it because it's just become really, really complicated. So I think colleagues might want to give specific examples, but our role as a health and care system is to just make it all work smoothly, make it really clear. So, Councillor Welsh's particular example of her father, we don't know anything, but actually you'd like to think that we'd have an urgent care rapid response service that could keep somebody like that at home, not even think about, and keep them safe at home, not even think about conveying them to hospital late at night. So I think we have to work on getting all these sort of flow points right. We have to recognise that, people are residents, they want to live at home, they want to be supported at home, and we have to get it all working properly. In terms of staff morale, every individual organisation is working really hard because we know we are only as good as our people. But again, you'll start to get job satisfaction when you see things work. So I suppose the best that we need to give people a sense of hope that we can get this better, that they will be valued when it gets better. And I think it is. And I know these sounds like platitudes, but it's a partnership between us all. And I think that's what we're trying to get ourselves in a position this winter, that we're absolutely confident that our processes as streamlined as possible, that we help people manage their health and well-being. They get downtime, they get annual leave, but that we manage to staff our services at peak points.
Thank you. Councillor Adams.
Thank you, Chairman. Hello. Just a couple of things. Around a preemptive mail shot around who, what, where and when people should go, potentially under certain circumstances. I wonder around, for example, a few months ago I found out that there's X-ray facilities at the walk-in centre in Nottingham, which arguably would maybe think of somebody that had landed on a thumb playing football, maybe to go there rather than to take themselves to an emergency department at a hospital. So I wonder about what are we doing to communicate those specifics, and also I understand that there's dental emergency work that can also be done at the walk-in centre as well. So again, you know, what are we doing to communicate that preemptively of this concern around winter? I also wondered about Councillor Welsh mentioned around this queuing system situation where somebody can potentially leave or leave to go somewhere to the loo or whatever and potentially lose their place. I wonder what work you do with the private sector, specifically in one area. This is going to sound like the oddest connection, but it's a systems, the way my brain works. Around things like, if you go for a Nando's, for example, they give you a buzzer, and you can go and walk around any area within roughly a mile of where you are. That gives you an ability to get back to that place. And when your appointment time happens, or your table in this case is ready, they buzz you, and you know that it's your time, and you head back to where you need to be. I just wonder if we're even looking at system possibilities like that. And if it, you know, in more of something that's used in the retail sector, which is around people tracking, people counting, you know, how much of that technology has been introduced as well to remove that need of guesswork and work out streaming, I think you called it, how you track individuals properly around hospital services. And I suppose it's just simple things that I think could maybe help. And I wonder if we are looking at those, and using all methods of communication to get to people, because, you know, as we're all acutely aware, not everybody has an iPhone, not everybody has a telephone even now. Some people have just got broadband only at home, but whatever, they may not have the capacity to use. And so ensuring that we get to everybody with those instructions about, if this happens, this is where you go. If that happens, this is where you go. Thank you.
Some good suggestions there for you.
So just on you lose your queue if you're not there. So firstly, if someone's not having worked in the service, if someone's not in the waiting room, you can't hold them, it's worrying. So this is not, are they somewhere, are they in a toilet, collapsed, is something more serious happened? So just to be absolutely clear, the absence of someone from a waiting room causes a lot of activity to try and find out where they are and what's happening. Not, oh good, they've gone, they've lost their place. This is a very different reaction. Now, it may not feel like that, but there is a real thing about managing a waiting list risk. And if people aren't there, there's a lot of effort to make sure that people are around or aren't somewhere collapsed somewhere, because it is an emergency department, people can deteriorate. And there has been a look about whether you can give people in the emergency waiting room devices to allow them to leave until their place has been called. But again, it's a very rapidly developing story, and it's difficult to manage the risk. There are examples of when people have been formally diagnosed that they can, in certain settings, they can then move around the hospital department more and be called back on buzzer devices. And it's something we will happily work with the emergency departments and their colleagues on. But in that very first bit, it's important to understand and manage the risk of people who often have just been triaged, not been diagnosed, about how we manage that risk in that waiting room. There's lots of processes go ahead behind the back scenes about people looking around the room, looking if people are becoming more unwell, the ability for people to come if they start getting additional symptoms. So it's one of the things that when we're working with Trust, we work very heavily with how we manage a waiting room full of people who potentially could get more sick more quickly. If there are examples of where people think they've lost their place, we'd like to hear about that, because it means that there's a fundamental breakdown in the process that we believe to be there. And we'd like to assess that further. So I don't know, Councillor Welsh, if there's things that you want to share with us that we might be missing, I think we'd happily take that forward. But fundamentally, the waiting room in the emergency department is considered a high-risk area. Therefore, monitoring, looking where people are, and if people can't coming in when they've been called, well, what's happened to them? Because most people will say they're leaving and won't just not be called in. So that's certainly my experience of working there.
Could I just add to that as well, please? Thank you. Thanks, Dave. I think the preemptive stuff is really important in helping our public anticipate the next step, what that might mean for them. So, you know, in some cases it's having a well-stocked medicine cabinet at home, isn't it? So you can take the first steps yourself. And that's not, you know, that's a really basic message, but it will make a difference to when you've got somebody with a high temperature you're trying to care for example. So I think that's a really important one. We've got kind of a winter well campaign that we'll be bringing out again, but I think we do need to focus on the anticipatory messages within that, because if you're looking after somebody at home who's terminally ill, there's significant things you can do that will keep that patient at home in a crisis. So I think the point's well made, and it's one we need to revisit. So that's the first thing I want to say. The ED department, as David explained, you know, there's specific safety and harm issues that we need to be really aware of there, but we are looking in our urgent care centres at what would the mix of bookable and walk-in appointments look like, so as we can try and cater for people's different needs, the NAMDO experience. So we are having a look at that with both providers to try and see how we can make that a bit more flexible that will work for people. So that's another one. And then I think innovation is actually, and technology, we use a little bit outside of hospital, and I think we're getting our act together a bit more on that around, you know, how can we use falls detection matting, how can we use self-monitoring for BP, oximetry, all sorts of things. So patients who understand their conditions or have carers that will support can keep themselves well at home and just get the advice by phone that they need. So we're building on that work. So that's going to help us. And that's all about creating the right amount of capacity so as our staff, in whatever setting they're working, don't feel overwhelmed by demand all the time, because, you know, there is, you know, a growing demand, and your husband's experience is real, and, you know, I'm sure there's lots of others that would, you know, kind of reinforce that. So we've got to make sure that we're innovating well, that we're putting enough workforce in where we can, that we're trying to put care in the right parts of the system, so, you know, in primary care, in community, etc. And it's a massive undertaking, but one that we've got, you know, good work going on in all places. It's not perfect, but I certainly think we've got, you know, we're well on the way to some of the best care being available, you know, wherever you present. Thanks.
I've got a few, unfortunately, obviously, through time. There's a lot to cover in this very small report that you've brought to us, which has got a lot of issues in there. We just mentioned about communications and campaigns. I think that's one of the biggest things in terms of making sure the campaign is well resourced and that actually is out there telling people where to go, how to help. Self-care has been around forever, but is very rarely given the level of support to do that. On the ED issues, Healthwatch has been very involved in looking at the improvements to ED. We've had a tour, we've looked round, so we've understood the ambulance drop-off timeframes and understand that that then adds to the pressure internally within ED. It's great that people are out of ambulances quick and ambulances are out there back on the road. That's really important. Having experienced Leicester myself, where I spent 4 hours in an ambulance, I really understand that it's very different in our area, but always can be improved. However, my questions are that additional demand into acute ED, how is that going to be mitigated? Because on our tour of ED, that was something that Healthwatch, that was something we were still concerned about in terms of what the additional pressures and some of the things, if you're brought in an ambulance, you then put into the ED department where there's people with eyes on you, but the experience of that for patient is something very significant. The other one is in your report, you look at some specific actions to support winter planning. Now I look at these and 1, 2, 3, 4, 5, 6, 7 out of 9 or 8 are all about putting more responsibility onto the community and the voluntary and community sector. Whilst as someone who's been a champion of the voluntary sector for many years, I welcome that that is now recognised as part of the system, but I would like to know what modelling has been done in the voluntary and community sector to understand their capacity, the demands on their services. We talk about sending people to food banks and asking councillors in their role to encourage people to use the voluntary and community sector. However, to my date, I'm not aware of any modelling that's been done on the capacity of that sector to actually meet these winter pressures that you are placing on them within your plan. So I'd like to understand what funding increases have been put into the sector to support that, or is it just a case of we're just telling people to go to the voluntary sector? The other area that I'm concerned about is the issues that you've mentioned, Melanie, around social care and support in care homes and at home. Again, when we visited ED in NUH, and apologies, we've not visited Sherwood Forest, so I don't have the same comparison, but there were over 200 people in hospital at that time who were fit to discharge, who were unable to discharge because there was no capacity to get them home. Now, that's one of the things, it's great to hear that there's more residential and home care than there was last year. But obviously you mentioned the impact of cost of living, staff pressures and etc. that's going to make that worse. So again, looking at what specific mitigations are we looking at that will reduce, which is what is happening now, and that's before winter pressures actually come into place. One final, I'm sorry, there's just so much in here for me. Looking at the community response teams that at the moment are doing brilliantly, it sounds, with over 800 referrals a month. That's fantastic. Achieving 90% of their targets against the national target. That's now. So what is this figure going to look like with winter pressures, and are they still going to be able to get to people within 2 hours to support people from actually going into hospital in the first place? Sorry, Chair, that was quite a few reflections.
No, Sarah, we welcome your input, so that very grateful for that. Thank you. Now, who's going to answer all of that?
So I'll take a couple of elements, if that's okay. Yeah. So emergency department flow, as I'm sure you appreciate, it's something that takes up a lot of mine and colleagues' time. Completely accept that some of our patients are waiting too long for a bed, and we are working with all of our acutes on some different models that will pull patients out of the emergency department quicker and distribute that increased volume of patients that need to move further through the hospital, so into assessment areas, into our wards more equally. And the idea is that if you move that demand further through the hospital, the wards and departments work more efficiently to move the most well patient home in the best way they can. Now, I understand, I recognise the figures that you talk about with patients that are what we call medically fit, ready to leave hospital, not being able to move on the day that we need them to move. We've done a lot of work as a system with social care support to look at how can we provide more capacity in our Pathway 1 discharges to get people home. The number's 8.6 million that we've invested in it in this year. We are building that capacity with our providers, but as I'm sure people are aware, the domiciliary care market is in recovery as well. Recruitment in that area is challenging. I'm sure Melanie can comment further on that. So we've got a range of initiatives that will work to improve flow, reduce bed weights in our ED department, and also support staff. So there's definitely initiatives around how do we keep the quality of care high for patients that are waiting for a bed within the ED department. So there's specific measures that we look at to make sure people are kept safe. We bring staff down from the wards to make sure they're hydrated, fed, etc. All the basic things we would want for anybody in a wait scenario like that. I think the question around urgent community response and the stats that you quote, that's an area of significant investment also, and we've got more nurses and care support staff recruited now and plan to be, you know, kind of in post September, October, November. So it's an area where I'm confident we can move demand quite safely and keep people at home. Yeah.
And just, sorry to add, I think it's an extremely good point, by the way, about modelling capacity in the VCSE. I'm not aware, unless Melanie is, that we've actually done any formal modelling. But you are absolutely right, because if we're talking about this as a whole system, every part, the capacity in every part of the system impacts on the next part. So that's definitely something that I think we should consider.
Melanie, did you want to?
So within public health, we have done work around investment in food, in the food environment. So that's completely out of scope of this committee here, but you might want to have a look at the Adult Social Care and Public Health Committee before we move to the Cabinet system, if you like the background of that, or the Health and Wellbeing Board paper, Sarah, because that's where we've done the work on the food clubs and modelling that capacity. Equally, the national guidance is that people should not leave hospital and go into long-term adult social care, whether that's home care or care homes. So Caroline's quite right. We have, as a system, invested in our short-term services to support people to recover before they move into longer-term services, or in my wish, to be discharged without any further need for social care support. So that's going to be a priority for us this winter, is about the discharge, to assess work and making sure that decisions made by the system are in the best interest of the person. So we're delivering that work through the transfer of care hub work, where we're looking at each of the hospitals, because remember we have 3, so we have Bassett Law, Sherwood Forest Hospitals and NUH. So looking at that interface with ourselves, community health, the voluntary and community sector, and the discharge processes in the acute sector, to make sure that journey home for somebody, because ultimately that's what we're after, is a journey home, is that, within their best interests and supports their needs.
Thank you, Melanie. I'm very mindful of the time, members, and we've got 3 more speakers, so we'll just try and keep it close. Just one thing that has come to mind that members might consider that we look at with Melanie's input. She'll tell us whether I'm on the right track. People are being referred to the voluntary sector over this winter. I think the question is, who are they? Where are they? What can they offer? And I'm wondering if perhaps we should be looking at some of the voluntary organisations, because perhaps when people go to them, they will say we don't have any funding and there's nothing we can do. So we can't really be referring people to the voluntary sector unless we know they're actually there with some help. Would that be a point, Melanie?
So if I might, I could have a look at this with Noel within the terms of reference of this committee. So I would suggest that potentially what is in terms of reference to this, given you're scrutinising the health service, is around the approach to social prescribing and the primary care network developments. That may well be part of the primary care work in January, and Lucy can confirm, but that's where the NHS's intention to build capacity in the sector is clearly expressed. So that will be my hint there. So you might want to look at that as part of the primary care
It's no good us
capacity
going
programme.
out into the communities and saying go to the voluntary sector if in fact those people can't help anybody and can only turn around and say we don't have funding. That's not really very helpful to anybody. Sarah, you wanted to come back on that?
Yeah, just for a point of information as well, the ICS, the ICB is creating a voluntary community and social enterprise alliance, which brings together providers within the system that are for services delivered by the voluntary and community and social enterprise sector. This is a way in which providers will be able to work better together, also look at how they might be contracted in the future, and something that all the major providers are involved with. That also includes how we will involve the smaller community organisations that don't often have the capacity to take on contracts, and work with them with wider providers within the system. Now, I mentioned that, I think, at one of the scrutiny and also in the Health and Wellbeing Board. That is at the moment being developed, so I think next year that would be a useful place to bring to this committee to understand how that is being integrated into the wider system and how the voluntary and community sector is being seen as part of the system, in order that services provided can be utilised to the max particularly at times like this when we've got winter pressures, and how they're involved in those conversations to ensure that, you know, demand is measured and supported throughout the entire system. So that's a point of information about something that will be around next year. I've been involved in it from its conception and intend to be part of that. But obviously Health Watch isn't a provider. We are a voluntary organisation, which is why we're involved, but we are keeping a watchful eye on its progress.
Thank you for that information. Right, moving on. Councillor Perdue-Horan, please.
Thank you, Madam Chairman. Most of my questions have been answered, fortunately. But there is one that I'd like to just ask generally across the board. Obviously, I'm very encouraged to hear that we're planning for what may be a very difficult winter, as they all are. But what I'd like to ask is, what's the general trend of recruitment at the moment for extra capacity, for more care workers, GPs at primary level, nurses in hospitals, and of course they'll all go up and down throughout the year, I'm sure. But what generally at the moment, how is it going? If that's part of the plans, we can do our bit by helping with Help Us Help You campaign, but that will only be very limited. What really matters, of course, is extra capacity in the actual health service and social care service generally.
Lucy.
So I can give a general start. I mean, one of the things I think is really key that when we look at our workforce development is that we do talk, I keep saying this, about a whole care system, and that we have parity of esteem across health and care. So it's not just about doctors and nurses and social workers. It's about it's about home care. It's about the whole care agency, whole care spectrum. And we do need to do that. We are carrying vacancies, however, across professional groups in the NHS against a growing workforce. So the trend is that the NHS workforce is growing, and we are having to, we're trying to, rather than rely on expensive agency type staff, work together, certainly as health providers and hopefully with care providers, to create sort of a collaborative approach to bank and development of a reservist model. So we kind of want to build our own workforce as much as we can, and we want to not just build it, we want to sustain it. So, I mean, the general trend is the workforce is growing. We are holding vacancies across the board. We want to create a substantive workforce. But we have to recognise, I mean, Dave can talk about this in more detail than me, we can't grow new GPs, so we have to look at that model. Melanie mentioned primary care networks that wraps around general practice. But so the trend is growing workforce, still holding vacancies. Could be a challenging winter, of course, with sickness and absence. But it's this kind of collaborative approach, so that we're not, one isn't drawing from another's pool. It's one sort of workforce.
All right, on that. Councillor Horan? Yeah?
Do we have a general picture in the care sector?
The Adult Social Care and Public Health Select Committee was due to consider workforce on Monday, yesterday, so that's been postponed. So I'd suggest you have, when we revisit that will be a good committee to have a look at. We're looking at care sector workforce in detail. But it still remains a particularly challenging position with staff turnover. So it's less about recruitment, it's much more about retention, the ability to recruit with the high degree of turnover in the care sector. But there are, across the adult social care market, because obviously we have 24,000 social care roles, we still are, the sector as a whole is experiencing some challenges there. So I don't know how many vacancies there are exactly across Nottinghamshire. But yeah, it's particularly difficult still.
Thank you. Jono.
Chairman, I'll try and be quick because I know I've already spoken. I wanted to wait until the end to ask this question because it's quite a specialised question that myself and Councillor Henry, we're ANFOS advocates. And the question that I have is, based on military, but based on film, we know that the suicide rate in young men at the moment is probably the highest it's ever been. Military personnel as well taken. I've lost more friends and colleagues from suicide than we lost in combat. At the moment in time, there's a gentleman on social media called Stephen Hilton, just pretty much had a nervous breakdown on social media for the world to see. And the amount of abuse that he got, this guy is having a nervous breakdown, he's tried to commit suicide, and the amount of abuse he got, because he's a man and he's a deadbeat dad because he's not looking after his children, no sympathy. And I think men in particular, I nearly tried committing suicide nearly 16 months ago. We don't feel there's help out there for young men. We don't feel the system is designed for veterans in particular, but men as a whole. There's no help out there for us, and it gets to the bleak where we are stood on a bridge ready for committing suicide or trying to take your life by taking drugs. What help is available? I sit on the military panels, so I'm aware of there's been massive amount of money put into these. They don't work. They do not work.
Jono, can I just
well, the reason why
this is winter pressures.
But the reason why I'm asking that is we're already seeing a massive strain on this in particular. And then we're talking about winter pressures that are going to make this even worse, because it's either do we focus on winter pressures and we put all our service provider into the winter pressures, or do we say that there's already something at breaking point, is there more needs to be done? And this is why I'm asking this question is winter pressures, yes, but we're already seeing pressures on services. And are we going to see more suicides, more people committing suicide, especially men, because the services have had to be pulled from elsewhere to focus on? Or have we got enough service? I do get where you're coming from, Chairman, but I just think it's really, really important that we look at all the services that may have a strain in the winter, especially ones that we know are at breaking point now.
Well, I'm sure Lucy will give you a quick answer on that, perhaps.
Yeah, absolutely noted. There are services, community-based services like the Tomorrow Project that help people with escalating mental health crisis. We do recognise the statistics about men. I don't think it's either or, it's got to be both. And I think what I would say with suicide prevention, there are services there, but we have to work harder to make sure that they're easy to access. One of the things we hear about some of our suicide prevention services, people feel they have to tell the same story to. The services are there, but they're not joined up and have to tell the same story to different people, and that's something we need to work on. But I think I can give you an assurance that those services, it's not either or.
Right, last but not least, Michelle, please.
Hope you mean that, Councillor Saddington. Just going back to the A&E department with regards to not knowing if someone goes away, don't think that happens. Really think perhaps people need to go and have a look what happens when people do go to the toilet or do leave, or when their name is read out. What people were doing the last 2 times I've been in there is telling the person next to them, this is my name, and if it's called out, will you tell them that I'm just in the toilet? So that was happening. So it was people creating their own kind of solution to it as such. But I don't think you necessarily, the safety measures that you talk about are necessarily happening, and I think perhaps that needs looking into. And then something else, Councillor Adams mentioned something really, really technical about how to water and feed people in an A&E department with regards to things that buzz. I'm going to go back in the day, the WI used to walk around with a trolley to the departments with food on a trolley and something with people to have a cup of tea or a drink of water. That is literally all people need in that A&E department. I take on board what it is, and maybe in the future that's the way forward. But actually there's a hatch in your A&E department with facilities behind it to serve and make drinks. You've got private companies in there, I know, but like I said, all there needs to be is a little trolley that kind of goes in there. And I know back in the day, either you got a green thingy or a red one, and that meant you could eat, and the red one meant that you couldn't eat at that time. But there are real simple solutions to making sure that people have got a drink of water or something when you're waiting in A&E for 16.5 hours, something that could be resolved very, very quickly. And that's just about being humane towards people that are waiting, that are really, really ill.
I think Councillor Adams is pleading to come back.
Sorry, I just want to clarify on something. It wasn't about food provision. It was about just, you were talking about the people that left the queue. And I was saying that if they had a buzzer in their pocket when their appointment was ready, they'd know that their time to see a GP or a doctor or whoever was ready. It wasn't about actual food provision. I'd just seen it in a food setting. That was what I was saying.
Okay. Well, the message is there. Can we think about that, please? Right. I'm going to draw a halt to this because I think we've looked at this in fair depth this morning. I think we, first of all, will thank you. Do you want to stay, may I ask, while we have the ambulance people speak? Do you need to get back, probably?
If it's okay, I need to go at 12:30, but...
You need to go at 12:30. What about you, Caroline? Anybody, let me put it another way. If any of you three would like to stay, you're more than welcome, but I fully appreciate you've got valuable time. So, my thanks to the three from NUH and ICB and wherever these days. Thank you very much. And to Melanie. I don't know whether you're staying, Melanie, but thank you to the three people from outside. We really do appreciate your help. We're not criticising in any way, shape or form, but we are trying to get the message so that these good people on the committee know what they're to go and say in the outside world and try and help. And I think my question would be, September, October, could we have you back in November to tell us whether your plan that you've very carefully laid out is actually working, or whether you've really got problems at the hospital? And by that time we'll know whether our people out there are mentioning that they've got problems which we can bring back to you. Is that a possibility?
Yes, I mean, we will, I think, possibly with sort of paper deadlines, we may, because it'll be where sort of activities really starting, according to our predictions, to grow. So we might be able to bring more to the discussion than we can perhaps put in a paper.
That's lovely. That would be helpful.
That would
so
be...
we're in September now, October, November, which is the 15th. Yes. Is that fine? We move something along. We're also in January looking at primary care and access to GP services again. And we are also starting to look at dentistry, which in effect is something that's been mentioned by Councillor Adams this morning, I think. So thank you very much to the three of you. I'm sorry we've kept you rather long. Perhaps you've got time for a coffee before your next meeting. Right, to the ambulance people. My goodness, I hope there aren't people out there waiting for you. They would have rather a long wait. Would you like to come and sit over here where I think people can see you better? That lady can come across here and sit in the front with the greatest of pleasure.
Just going to fetch the others as well.
Oh, we've got some more people coming through for the next next briefing, so it's all right, don't worry. Thank you very much. Yeah, I need to go, but I'll wait. Thank you, Melanie. You're going too, are you? Can you manage? Would you like some help? Well, you come where you feel most comfortable. Would you like to sort of sit there? You're very welcome to sit where you'd like. Do you need any help at all? You sit where you feel comfortable. Sinead, your phone was ringing with great urgency. Is everything okay? It's not your little doggy. He has priority. Pardon, you're moving round. Yes, Sarah, you're welcome. We're going to... Yeah, I'm aware that there's another committee. Yeah. Members, I'm going to start straight away because we have other committees starting at 1 and we still have some more guests here to talk, give us a brief brief on dementia. So we do need to move on with the ambulance. Good morning, good afternoon to everybody, and good afternoon to the dementia people on the back. By that I'm not being rude, I'm saying you'll be giving us a brief briefing on dementia. So can we move forward with the ambulance group, please? Thank you for coming. Sorry to keep you so long, but it was half about you, wasn't it? Right, okay.
Thank you, Chair. And first of all, I'd just like go back to earlier and thank you for your kind and supportive comments around why we're here and that you are all here to support us. That was very much appreciated. So thank you for that.
Yes, we're not criticising.
Absolutely not.
Totally in support, and we know how hard a job you've got.
Thank you. We will go through the presentation at pace, I think, because I think we've all found already it's the conversation that then generates is what's valuable rather than the presentation itself. And very quickly, you sort of get from the presentation, it doesn't look specifically at winter pressures, but what we've tried to do is, and I think it's one of the councillors made the very point, I think it was about mental health, but I think it's generally accepted that our theory being that we want to get all our services right all of the time, and therefore that will then put us in good stead for winter pressures. So they're a little bit more generic than winter pressures. So very quickly, slide 1, I'll say very little about. It was just more about assurance on slide 1 that for our most immediately life-threatening calls that we receive, although you can see from the graph on the left-hand side, our activity is going up, and quite significantly on that. Our performance against that, whilst not quite at national standards, is generally speaking maintained. So a level of assurance for this committee on that one. In terms of slide 2, what you'll see, and we have talked about this earlier today, is a worsening position on our category 2 calls. And so I'd expect the committee to say, so why is that then? Lots of reasons, as you would imagine, over time, but we can't say activity. But if you go to slide 3, if we may, one of the reasons, and we did talk about this quite a lot earlier, and I quoted some of the numbers here around some of the pressures that hold us up in terms of we're not able to respond, and therefore we can't hit those targets where we're delayed in hospitals. I think what that describes, and what I was saying, I don't want to hide behind data, but in terms of what EMAS does and what it experiences in Nottinghamshire as opposed to other areas, I think the graph on the right-hand side is very telling. So we lose approximately 73 hours or 70 hours a day to hospital delays in Nottinghamshire. So our task, I suppose, and one of our preparedness for winter, and we've agreed some actions with our acute colleagues, is to reduce that to 0, because we don't want any delays, because they're 70 hours a day.
Can we just, you've just got somebody wanting to ask a question.
Sorry, yes.
Sorry, just really quickly. So 70 hours a day of lost time, how much does that equate to money-wise? Do we know, like, and not have an idea of how much that actually means?
I'd have to take that away and come back to you in terms of certainly, yes, we'll take that away as an action. Sorry, I don't know that one, I'm afraid, but I will take it away as an action.
Sorry for that.
No problem. It's fine. So 70 hours in every day that we could be responding to patients in Nottinghamshire, so we accept that needs to improve. What a point, it doesn't make it right in Nottinghamshire, but what you've got to see from that is that across the East Midlands, that's 600 hours a day. So in most counties, it's significantly worse than what we're experiencing in Nottinghamshire. So still work to do.
Just hold it now till the end, because if we keep interrupting, he'll lose his thread, perhaps.
No, that's not a problem. Was on, and the last slide that I'm going to present on, sorry, if you just go back one, I think. I've done the handover slide, so sorry, over to my colleague.
Thank you. So I'll just talk a little bit about our winter preparations. As with NUH colleagues, we have access to lots of data and we use that to build year on year to predict our activity and that helps us maximise our resourcing to try and mirror the peaks and troughs as closely as we can with our resourcing there. Of those calls that we know are going to rise throughout winter, we have clinical assessment teams that work in our control centres that specifically deal with the lower acuity calls and are able to deal with those calls through advice or signposting that enables us to prevent having to send an ambulance in the first instance and therefore allows the ambulances to concentrate on the more likely patients that are going to need more additional support or attendance at ED. We work with our acute partners through daily system calls to understand each other's pressures and how we can support each other in various areas to try and lessen that load at various times through the day. And we have our community first responder teams where we activate them to non-injury falls. So quite often we have patients that fall but are just unable to get up. No injuries, but they can be some of our lower acuity and longest waits. So our community first responder groups are able to target those with specialist equipment that will help them to get a faster response and hopefully for them to remain at home. And going on to the next slide is around quality and safety, and obviously just some assurance that quality and safety is our priority. So we work very hard to ensure that our staff are up to date with all their relevant mandatory training and also have access to anything being updated through the system, so pathways, safeguarding processes, infection and prevention control, to name but a few. But there are lots of systems in place to help that smooth transition and keep them updated with things that other partners are also doing to support patient safety.
I'm on now, sorry. Apologies. So I'm going to go through, if we go to the next slide. Thank you. I'm going to talk about how we support our colleagues now and obviously going forward in the future and certainly through the winter periods. But we have the National Staff Opinion Survey, which is done yearly, but we also do regular temperature checks locally within NOTS, just so we can understand what concerns and issues staff personally have. And we pride ourselves on, you said we did, so that when we do identify issues that are important to colleagues, we do something about them and we communicate what we have done about them so that staff feel absolutely listened to and supported. We've recently procured a new occupational health provider so that we can ensure appropriate well-being throughout from now moving forward, but that's going to also incorporate physiotherapy, specialist advice, and also supportive therapies. We recently had a new management structure, I say recently within the last year, which improved the accessibility to leaders locally. So again, staff feel listened to, because they can discuss issues and concerns with their frontline managers in real time. And in addition to that, we have Station Voice, which is a monthly arena for staff to raise concerns. Again, it's raised real time, and it's all of us sit on that meeting so that we can address what staff feel is important to them. We've also introduced a mental health development lead to provide mental health learning to our staff. That's a very recent post, but it also allows our staff to understand what services and facilities are available to them personally as well. We also are committed to supporting flexible working, which we find helps to retain our frontline colleagues. Obviously, the flexible working comes in line with ensuring that we deliver a safe service. And it's also important that we ensure that the journey for our new colleagues, our new apprentices that are starting, is a positive experience as well. So we have dedicated mentors for those through their learning experience. We've also established a number of professional development workshops and education opportunities. And the biggest story for our staff is the relocation of Newark Ambulance Station. So we're going to co-locate with Notts Police to a newer building in Newark, and we're ensuring that there's early staff engagement now so that they're engaged in ensuring that the facilities in their new station is what they want. On to the next slide, please. And we covered off earlier on about reducing conveyances to an ED department. So firstly, apologies, there are two similar slides here, so I'll run through this one. But it's about working with our system partners, and you can see from the bottom of the slide the number of partners that we currently work with to try and reduce those ED attendances. So it's ensuring that we get patients the right care in the right place to meet their needs. As I say, to introduce a number of ambulance conveyances to Type 1 emergency departments. There are a number of pathways that our clinicians use, and I'll go on to the data on the final slide. But that's also encouraged by our pathway ambassadors, who are frontline colleagues who have a keen interest in looking at pathways that are currently available, and they communicate those and engage with that peer support to ensure that people know what pathways are available. And we also run regular workshops with colleagues just to make sure, again, that they're absolutely aware of the pathways that are currently available. And what we do as system partners is to meet regularly to ensure that the pathways are accessible. Obviously, we don't want the list of pathways where colleagues have issues obtaining the appropriate care. So you move on to the last slide, and it will show you, there we go, so thank you. And it will show you our current success within Notts, and that for July, we only took 48% of patients to an ED department. The rest were discharged at scene. And we do regularly review patients that attend ED, and we're absolutely assured on the majority of occasions, those patients that we take to an ED department do need to be in hospital. But 48%, I think, is a significant figure for not conveying to an ED department. And that's our last slide.
Thank you, gentlemen and lady. Your category 2 is clearly causing a problem. How do you think you can address this? I mean, I realise it's not really in your hands at the end of the day, but if there are people out there ill and you can't take them to hospital, how do you think with winter you're going to be able to improve on this?
It's certainly, as you say, not all of that is within our gift to resolve, but certainly parts of it are. I think Annette described that what we're continuing to try to improve on is our prediction, and there is quite some science around predicting what times of day you get calls and you get your peaks and troughs. So we're making more effort to try and hone in on those predictions we get. I've already mentioned that with our acute colleagues at the 3 hospitals in Nottinghamshire, we've agreed processes to reduce that 73 hours lost hours that I talked about, that, as we said, gives us a financial pressure, but gets us the real pressure. And I think that's the key to this. There's some recently across EMAS, there's been some work. We bring in additional external specialists whose role it is just to look at our workload. And part of the predictions they're making is that actually Nottinghamshire as a county, if all of the things were equal, would actually be able to service its community quite ably with minimal investment in terms of extra resources. what we need to do and what this presentation was designed to do to say was, so what it means is, as a system, we have to be more efficient and make sure the resources that we do have to hand, we are able to use them. So no easy answers there, no quick fixes, but certainly efforts are being made to improve on that category 2 position. Yeah.
So I think that is one of the questions that we get from the public. Jono, you wanted a word in the middle, so...
Chairman, thank you. I wanted to dig down a little bit on this 70 hours of wasted time, and I am calling it wasted time, on the handovers. So 70, a few questions before I ask my main question. How many crews on average do you have per day, and what are their shift patterns?
We have upwards, our maximum would be 40 plus crews, but we have crews coming on practically every hour of the day, so that is spread, say, across days and nights. Some are 8-hour shifts, some are 12-hour shifts, so it's difficult to say at a specific time, but I say our maximum would be 40 plus crews.
I'm going to take it at 12 hours because it's easier maths. So I've worked out 70 hours would be 2.9 days lost on average. I've worked that out between 4 and 8 crews that would be sat around doing nothing. That's a massive percentage of people sitting around. And okay, they're not sitting around doing nothing. They're not. They're waiting. They're looking after them. They're handing over. So they're not sat around doing. And this isn't a criticism to you whatsoever. This is just a massive number. A massive number. So that's nearly 10 crews that are sat around waiting to hand over that could be out. No wonder your figures on the less urgent are so high, because you've got 10 crews that are unable to do anything. So the question I have to you is, what do you think could be done to help you do your jobs better? And what do you think is the magic wand of being able to resolve this issue? Because at the end of the day is we have the ability to go away and speak to, say, Robert Jenrick, who's now the Secretary of Health, being able to pass over your concerns and what you need to be done. So what can we do to help you is the simple question.
Thank you. And of course, as we all know, there's no easy answer to that one. I wish there was. And I wished it was as simple as EMAS needs more money to invest in extra staff. But I've already said to you, and being on it open as I can, in that I think in terms of Nottinghamshire specifically, a lot more money for EMAS wouldn't cut it on its own. It's not about lots of more staff. Yes, there is an identification that we could do with more staff, but as you've clearly described yourself, it's the hours that we are losing is where the benefit will be given. And I think therefore in terms of investment required, and I think we described it earlier in terms of when the ICB were talking, it's more about that patient flow, and it's more about what availability hospitals have to discharge patients to, because that gives them the difficulties of then taking the patient's offers. So I don't like to use the word efficiency when we're talking about patients, but that's what it is really in Nottinghamshire. It's about the system having the ability to be more efficient. So I'd love to say it's for the ambulance service, but I don't think in terms of Nottinghamshire it is.
I really appreciate that honest answer. It's quite nice to get an honest answer and not just blame government or blame we want more money. So no, I really appreciate that, and thank you very much.
Thank you. Have we any more questions? Councillor Wilmot.
Thank you very much, Chair. First of all, I'd like to thank the EMAS service that's been provided at the moment. It's excellent, and it's tremendous work done by all staff. But we do have, as I say, a minority of questions that we need to ask to get things put right. I mean, we've all heard of the stories of people with life-threatening conditions turning to taxis and things like that. It has happened. It's unfortunate when they're wanting to get to A&E, and others waiting hours for an ambulance. That has happened, unfortunately. Sorting out our ambulance crisis should be a key priority, and I welcome the continuing efforts of EMAS as contained within this report and its appendix. Could you detail exactly what support you need from government to assist to improve the service? The other thing is, of course, the increase in fuel costs. I just wondered where that puts you in budgetary facts. Have you received more money from the government to pay for these extra resources you require for the fuel? Because the fuel prices have gone through the roof, as we all know. I just wondered if you could tell me a little bit about that. And what's the financial impact to EMAS in respect of the average daily lost hours? I just wondered if you knew that possible. Thank you very much, Chairman.
Yes, certainly. If, in reverse order, I've already sort of suggested about the financial impact of the lost hours. I don't know that, but I've made a commitment. I will go away and try and get you a number on that one. In terms of, I think you've again sort of asked how this committee can help in terms of EMAS delivering and improving on some of those long delays. I think I've already described that actually in Nottinghamshire specifically, the answer doesn't necessarily lie in high investment in EMAS. That said, as we go into winter, certainly we do see increases in calls, and we do sometimes, whilst we're very efficient as an ambulance trust in terms of being able to answer those calls, then having the appropriate clinicians within our control centres to support people, as Annette described, a part of our nursing teams in our control centres do support, as we've just talked about, up to 20% of our patients who don't even get an ambulance. We support them through our call centres. So there's always worthy of investment in terms of more nurses to support that. But I think we also describe within the ICB, what Lucy described is what we've got to be very careful of, that we just don't start taking other people's workforce. So we do work with the ICB in terms of trying to make sure we don't do that. So the support for us, as I say, is more about assistance to the system in terms of ensuring that flow for patients and some specific support around our control centres and what they can offer to support and advise our communities. Is that?
If I just come back on, you realise that the Category 1 incidents are the most critical, but the Category 2 calls are also very, very, can be immediately life-threatening. But the crews significantly didn't manage to get to the calls in the targets all over the area. And some residents were accused of over-exaggerating the health issues of others to ensure a quicker ambulance response time. How often does this happen, and what are we doing to educate residents about the need to be accurate when calling for help?
Yeah, it is a good point and a difficult subject, in the sense that we would never discourage anybody who legitimately requires an ambulance. We wouldn't want to discourage anybody from calling for an ambulance, but you're absolutely right. It's national triage systems for ambulance trusts that they're nationally set, so that's not something EMAS invents itself. It's worked through a national programme. But they are delivered by non-clinicians, so they can be a little bit generic. So therefore, what often happens when crews arrive at patients' addresses, what they're presented with can be somewhat different to what the information previously provided is. I genuinely, but anecdotally, don't believe, as a rule, I think our public are very honest citizens, generally speaking, and what they state when they're providing that information is on the whole correct. In terms of advice, I think certainly our communications teams with EMAS work hard through our winter preparedness to inform our general public about the appropriateness of the call. You see campaigns, even on this side of ambulances, we have advertising campaigns about the appropriateness of ringing for an ambulance. But as I say, it is a bit of a wicked problem, because what we wouldn't want to do is discourage people who actually need an ambulance. We wouldn't want to discourage anybody from calling.
Thank you, Madam Chairman. Very quickly, I've got no question, but I would like it noted that we support the individual paramedics, and I declare an interest in that regard, having the benefit of being a passenger in early January on 2 occasions. And I'm pleased to see that you've laid out here steps you're taking to support your staff. Because whilst the representatives I met were absolutely first-class representatives of EMAS completely, we have picked up, my colleagues have picked up that morale is an issue, and specifically creating retention issues, and mainly, I think, I understand, just being parked outside A&E. So, thank you for the efforts that you're doing, and as I say, I would just like to pass on my thanks for the experience that I've had this year and in previous years, despite all the difficulties that clearly EMAS has been facing in recent years, and I hope it moves forward.
Thank you. Thank you very much. Councillor Welsh.
Yeah, apologies that to nip out. This meeting gone off in my community is quite urgent, so I apologise for that. But I was listening outside, so I didn't want you to think that I was being rude. There's one real quick question, again, about people that are working on your ambulance and your paramedics. Because you are under a lot of pressure, there's no doubt that you're under a lot of pressure, and that may be affecting the welfare, and I talk about this a lot. I am concerned about people that work within the NHS and the welfare and what they have been through, what they've seen, and the continuing strains with regards to it. But are there growing incidents of how people react to you when you turn up to people's houses? Because people perhaps have been waiting longer than what they think they should be. Is there a rise of cases, and is there anything that needs to be done with regards to that? Are there growing issues? Because I know there's always obviously been cases where people don't react or don't behave towards people on the front line as what they should do. I'm just wondering if that was on, as the pressure mounts up for you to deliver a service, and you can't always deliver what, some of it is what people think they should have, isn't it, as well, not necessarily what they should be having. Is that, are vulnerable? Are they becoming more vulnerable? Would be my question. Are you well? Do you feel well protected as a workforce?
Thank you. I think you're quite right in that our staff are often subjected to less tolerance out there nowadays, sometimes through lack of understanding of what the ambulance service is about nowadays. And so we don't just take everybody to hospital. If it's not appropriate, then we'll signpost to something that is more appropriate, and people aren't always expecting that. I think, unfortunately, there are an increasing number of calls where staff can be subjected to either verbal or threatening abuse, and we take a very zero tolerance towards that. Our staff now have access to body-worn cameras so that we can gather evidence when these sorts of instances occur, and we can then take that through with the police and prosecute if appropriate. I think you're right in that there is we do offer a lot of support for staff post-incident. So we have managers that will meet with staff if they've been to a difficult incident, and we'll talk it through and offer support that way. And as Bill alluded to in his slides, we've got more support than ever for staff through various services that we're able to offer. So whilst it is increasing, I would like to say that we're very aware of it. We're very much better at recognising it and therefore dealing with the support that's available to staff to prevent it becoming a longer term issue.
Thank you. Just really quickly, the progress to date with the reducing conveyances, really, really good. But just quickly, how does it compare with other services? So the 48%, is that good compared to other areas? And the other one was, is the 48% going to be maintained, do you think, with the increased numbers of people you're going to get over the winter period?
Yeah. In terms of is it going to be maintained? I think you're right to pick up on that point, that I think there comes a point at which you mean a level at which it is appropriate, because what we don't want to do is just carry on not taking patients to hospital when actually that is the right place for them. And we have been specific in its conveyance to emergency departments, because it might be that overall our conveyance rates don't reduce as much because it is appropriate to take them to other places of safety. So that's the difference. How do we compare? Again, I'll have to give you a second commitment. No, that's fine. I'll give you a second commitment to say how we compare nationally. We are in the East Midlands, if you like, in second place to Leicestershire, who have a lower conveyance rate than ourselves. So I can tell you what regionally, but I'll make a commitment that we'll send both of those numbers to you if that's okay. No, that's fine.
Thank you. It's all right. The paper that is in front of you has been circulated. I can answer, or we can try and answer any specific questions, but I'll go straight to the current situation. We had to pause delivery of our strategy due to the pandemic, and we have restarted after a delay, year 2 of our 3-year strategy. The staff training numbers are well above 85%. We have close working relationship with the States Department at NUH, and we are, every new development that is happening building-wise or any building work is checked with the dementia standards that we have put in. We have an electronic system now of all admissions coming into, all over 65 admissions coming into NUH to be screened for delirium and dementia. We have started a pilot program where the referrals for somebody suspected with dementia are moved. We are able to refer them directly to the memory assessment service. This has taken out a significant number of steps. So we don't have to go through the GP and GP to do all the investigations. We can do all of that ourselves. Our staff are now being trained for advanced care planning. So we are in close working relationship with the dementia societies, and we have adapted their paperwork to develop a system where we are encouraging people to take decisions regarding their future, which includes a form, advanced care form, or respect forms that are being used in other places. We have now a very comprehensive dashboard of monitoring all aspects of dementia care delivered within NUH. So we monitor readmissions, number of deaths, number of assessments taken place, and we are working with the Nottingham's charities to produce a arts coordinator post and Megan will be able to tell you more about it in a minute. We are using a device called RITA, which is the Reminiscence Interactive Therapies activities. And this device has really transformed some of the care that is being delivered on our wards. And we remain a partner with the Alzheimer's Society and the Dementia Alliance, and we are delivering training sessions for volunteers and our staff within that. The key areas of focus at the moment are use of pain assessment, increasing arts and music provision, reducing the number of patient moves when they have suspected dementia, improving the environment in the outpatients at the moment. So this work has been done an inpatient, but we are now working on the outpatients, and we are working towards sharing information between primary and secondary care. We are also developing a recognition system for patients with cognitive impairment coming to our outpatients, so that information that is produced out of that appointment is shared with carers as well. In conclusion, we've had some delay because of COVID, but I think we are well in advance of the year 2 of our strategy now. Do you want to add something?
Thank you. So I think from a senior corporate nursing representation, the training has really been something that we've prioritised despite of the pandemic pressures that we've been under, because the impact on the patient is very well recognised. And the support for the carers has been something we've had to work alongside bespoke through the time when the visiting was restricted. So we have done a lot of work on that. So Megan's particularly keen to just share with you the artwork, if you have any time to talk about that, because it has a massive impact on the experience for the patients.
Thank you. So I came into post in September last year as arts coordinator for the Trust, with a focus on patients with dementia and staff wellbeing. So this came out of COVID really, with restricted visiting. So we've put in place a number of projects to both enhance the visual environment for patients, carers and staff, and also improve patient experience on the wards. So just some examples. So Rita has been massive in getting music and movies and entertainment to patients on the wards, and things that they can engage with, both with staff and other patients. So that's been really key. We've also supported staff, so we have a number of staff arts champions now who are ward-based staff, and they promote arts and activities for patients, particularly those with dementia. And they have also been through some training sessions, including a training session around music and how it can support care. In terms of visual arts, we now have 2 new exhibitions that we have worked in partnership to develop with paintings in hospitals. And these exhibitions, the works were actually chosen by patients on the older persons wards to stimulate reminiscence, conversation and memories about home and work, pets and anything that just ignites nice memories for them. And we're also working on getting some paintings and creating activity rooms on several of the older persons wards as well.
Well, thank you for that. I'm just going to, before I hand over to members, I'm just going to ask you something, 1 or 2 things. You've started a pilot with the memory clinic. What are the waiting times if somebody is down? That's one question. How long would one have to wait to be assessed or whatever? You take patients on the wards. Is this at City, a hospital? Where I'm just wondering where the patients go, because presumably the process is slow. So how long do you anticipate them to be actually on a ward? That's a question. No, obviously not.
No, it's fine. I just wanted to clarify that. Do you mean the patients for the memory clinic, or in general?
Well, it was implied, unless I didn't hear it right, that they're on the wards. So yeah, I wondered, Which hospital?
Yeah, both.
And for how long would
Yeah.
you expect them to be on a ward? And my final point is, do you consider that there's been any advance of dementia from people having had COVID?
Yes, I think.
Thank you. For the first question, the memory pilot, it's a referral system, so we have no control on what is the waiting times for the mental health trust. What we have done is removed a number of steps by ability to make referral ourselves. Previous methodology up to 3 months ago was we identified somebody with dementia, but we can't diagnose them. They were sent back to their GP. The GP would do a number of tests and order some tests, scans, etc., then collect all that information and then make a referral to the memory assessment service, which is delivered by the Healthcare Trust. So what we have agreed with the Healthcare Trust is to bypass the GP, so be able to remove all those, and I counted 7 steps at point that a GP would have to do. And so GPs have really welcomed that. It was to reduce the GP workload. It is being monitored at the moment. It hasn't caused an increase in the workload at the NUH Trust because the patients are still the same. They are making, I am aware of that, making a lot of progress in reducing their waiting times. There is another scheme that is going to be introduced later this year, which would allow care home residents with possible dementia to be diagnosed in hospital. We are still working on that. So these are steps being taken to reduce the waiting list. Second question, you asked where are these patients? So these patients are scattered around the hospital, but mostly in elderly care wards, which are based on both sites. We do not anticipate discharging them to the mental health trust unless they have got specific mental health needs. They are going to be discharged in a normal way. It's just improving the recognition and the care that needs to be delivered when they are discharged to a place of destination, which could be a care home, their own home, or waiting for an assessment. The third question, what was that?
I'm sorry. Do you consider that COVID has made a big difference to people?
Yes, sorry. So COVID has 2 aspects to it. COVID, there is a condition called long COVID, and long COVID is what experts have described is a continuous inflammation ongoing or continuous viral infection ongoing. Now that causes delirium, and that causes what is most people have described as brain fog. That can occur in younger people, older people, and middle-aged people. That doesn't discriminate what older people have. That is slightly different to dementia. However, COVID itself has caused a lot of loss of interaction between people. It has caused loneliness, social isolation, and that itself has had an impact on mental health of people who may be managing all right but have now developed severe symptoms. And we have seen that, and all these improvements that we are trying to make have. What I'm trying to say is that one thing that we have learned from delivering the dementia strategy in the last 2 years is that we can't make a strategy and try to deliver it. We've had to adapt it all the way. And this pandemic and the long COVID and social isolation has made us change the way we are wanting to deliver service for older people with dementia.
Thank you. Thank you very much. Councillor Perdue-Horan.
Thank you, Madam Chairman, and can I thank Dr. Ali and Megan and Sue for coming to see us today. It's been very timely because, as you will be well aware, Tomorrow, Wednesday the 21st of September, I believe, is World Alzheimer's Awareness Day. And I understand that Alzheimer's disease is the most common form of dementia. According to new analysis by Future Health, a healthcare policy research consultancy, it suggests that more than 325,000 people in England alone may have dementia which is undiagnosed. They claim that the impact of the COVID pandemic has led to dropping diagnosis rates, which are falling short of the government's target. The report also claims that the Midlands has the highest number of undiagnosed people with dementia. My question is, what are we doing to encourage people to get tested for dementia? And do we have any sort of handle on how many people in Nottingham or Nottinghamshire are perhaps suffering from undiagnosed dementia? Thank you.
Thank you, Councillor. Your question is quite right. The dementia strategy was written with that in view. We wanted to diagnose everybody who's coming into hospital, and that's what is within our control. So we don't run the dementia service. We are not the memory assessment service. We look after people who have come into hospital who may exhibit signs of cognitive impairment, Alzheimer's disease, vascular dementia, other types of dementia. And we have started working with our colleagues to identify them, to try to differentiate between what types of dementia they have, and making plans and making awareness of people where they would need help with their cognitive impairment. So that's within our gift to do. As far as encouraging people to talk about dementia, we have put on a number of sessions across last year since the pandemic restrictions were released. I was just remembering that 2018, 2019, we put on a number of sessions for the community to attend. With other colleagues from Rushcliffe area, we presented to people what is the work that we are doing and what do they need to do and how to improve care. I myself go to a number of meetings. I attended the annual conference of Alzheimer's Society in London last year, and we present that data that is coming out of there across the ICB. I sit on the chair. I sit as a member in the ICB Nottingham Dementia Society steering group, and there I have raised this a number of times, how we need to address the dementia that is not diagnosed, and the steps that we are taking about direct referrals and be able to diagnose those people who have gone past the stage of diagnosis, now are suffering from severe but never had a label. That is being addressed. As far as prevention of dementia is concerned, prevention should start in a 40, 50-year-old. And that's where general practice would need to raise awareness, and we'll be happy from the hospital point of view to put up any sessions if the committee feels that we should be doing that.
A very quick one, Chairman. I visit a lot of care homes in my area. In fact, I'm going out of my area now, but I visited one quite a way away just recently. And yes, it is a real problem, dementia. Different types of dementia, of course. But I'm really interested in that you're increasing the arts and music provision. I saw a lot of people trying to help them with dancing lessons and things like that, lovely music behind, but not having the necessary expertise to do it. So where can these people in care homes that are willing to volunteer can get the necessary information and expertise to be able to do this situation in that department? And there's a lot of volunteers would love to train to help with carers with people with dementia in care homes. Where again, some of these people, where can they gain the necessary knowledge to be able to do the work? Because there are people saying, well, I'd love to help, but I don't know how to help. You know, and that's a situation we all should get involved in, make sure that it's a possibility. And can you explain to me, in integration of dementia-friendly principles, including all what you've got down as, does that help people with serious dementia problems? The purchase of a clock, location and signage of toilets. I'm just trying to see what that actually means. And as I say, I do feel an increase in arts and music provision is a good idea, and it does increase the participation of patients. It's a tremendous thing, and if we can get it going in not only hospitals but care homes and everything, it'll be a superb situation, you know, and get people really interested. Promoting more carers involvement, as I've already said, would involve more training for staff and volunteer carers. Have you got the capacity to do this? I just wondered, you know, if you have got the capacity to do this, you can perhaps tell me. Thank you very much, Chair.
Hi, so thank you. So at the moment, obviously the role is really quite new. We're just going into a second year, and my post is funded by Nottingham Hospital's charity. So in terms of arts and kind of training, I think it would probably have to be kind of outside of the hospital at the moment. So I know a lot of people might study a particular arts subject and then can go into arts therapy and different things like that. And also charities might have the answers in terms of the exposure to learning about how arts can support patients with dementia as well. What was the other section that I was going to say? I can't remember how I was going to add to that, but yeah, I think we do have volunteering opportunities within the hospital, and they are just under our general NUH volunteering, and we do have opportunities to be arts engagement volunteers, which doesn't require any specific training other than going through our volunteer system, and then we just make sure that we place the volunteer with a person that's already doing arts and activities on the ward so that they're supported all of the time and can learn from that. So I hope that's helpful. Sorry that I can't answer that.
I just wondered if you actually advertise that situation, you know.
Yes, so it is on our website. It's relatively new because obviously we're just coming out of a time where we couldn't have volunteers back on the wards. But yeah, it's relatively new, but we will continue to promote, and it is on our website and available for everybody to view.
My question was answered at the beginning, Chairman. Thank you.
Thank you. Yeah, just reading the report regarding staffing, you mentioned how the training is very important and very useful. I noticed that you mentioned 85% compliance of the mandatory training, 85%, not 100. And you've mentioned in year 4 that you want to do more training. Just want to almost put it on the radar that what's going to be done to make sure that you're making sure those people who've missed out the training have the opportunities to do it, and those future training opportunities, how we're going to make sure that the take-up is as large and as wide as possible. Thank you.
Thank you very much. So our mandated training as a whole has been a focus that we've had to do a recovery programme on. We have clear trajectories for all mandated training, including dementia, and this is one of the highest compliance figures actually, but our commitment is to get from 85 to 90, then to 95, then to 100 by this time next year. But the bottom line is releasing our staff for that focused training, and we would be naive to consider that we could commit to it through the winter when our staffing levels will be at the highest demand and our sickness levels will be at the highest. So we're very committed to keeping the momentum going, and as much as possible we work on a multidisciplinary approach to the ward provision so that people can be released.
There's also one of the things that we have such a large staff number and there is usual turnover all the time happening. So when I have looked at the staffing specific groups, the doctors change over every few months, so they will never achieve 100%.
Thank you very much. Oh, Sarah, would like a word.
Thank you very much. I absolutely understand the pressures, particularly through COVID with this particular patient group. However, one of the key things that we know from the research we've done at Healthwatch, the experiences of people, that it's the most traumatic experience for somebody with dementia going into hospital, not only for the patient but also the carer. And it's great to see that you're increasing the amount of training that's there, especially around the recognition of delirium, which I know comes hand in hand for many people with dementia coming into hospital and is often not seen. Some interesting research being done that shows that clinical staff don't often understand that somebody's got delirium, because it's only when a familiar person comes in that they start to talk about being at a train station, for instance, and needing to leave the ward. So that brings me to the point about the involvement of carers and how important that's going to be. And it mentions in your strategy that you've not been able to do so well because of the pandemic. So I understand the issues of other people coming into ward, but I would be interested to understand more about how you are going to involve carers and families, not only to support people while they're in hospital, but also the information and training that's available to carers. Because one of the key things that we've understood is that they understand their person better than anybody. Coming into hospital, things, especially if they've been moved around wards, causes all sorts of problems. But how are you going to integrate the carer into the support whilst in hospital, particularly on long-standing stays?
Thank you, Sarah. So there's a couple of things. It's very clear that we've done some reflection on our initial responses to the visiting restrictions within wave 1, and we significantly changed those in the subsequent waves. We've also built in some confidence in our staff to be in a position where we absolutely individualise the decisions we make about who comes when the person, the patient, needs the care. So it's about our education to the staff that it's okay for carers to be there whenever it's appropriate for that person to have them. So that confidence is definitely built again now, and we have kept that momentum going. The point about the training element of further support and ongoing support is a really good one, and it's not something we've got ready-made answers to yet. So definitely something we need to work on within the strategy and get the detail behind it, because we haven't focused specifically on that yet.
Thank you very much. Right, I think with that we can draw this item to a close, and once again I will thank all three of you for coming along. Thank you very much, and to the ambulance service who we've nicely kept waiting, but we're not going to delay. Sufficient for me to say thank you to all our visitors, and I'm sorry that the meeting has extended. Thank you to all members and to officers. Next time we'll be discussing dentistry services, which I know is important to many, and the Healthy Families Programme, health visiting. But what we are going to do, members, if you look on page 44, we need to look at the discharge to access from hospital. Clearly, this is going to be very, very important through the winter, and it's suggested that we have a sort of meet-up with the Adult Social Care and Public Health Select Committee. We need to discuss it all together because it goes right across all three committees. But clearly, it's going to be very important as we move forward with winter, with people not being able to be discharged from hospital because there isn't anywhere for them to go. So we need to bring that forward. And also, we'll discuss dentistry, because I know a lot of people are having problems getting a dentist. So, as always, these committees are extremely heavy work-wise, but thank you to everyone. Just before we go, Sarah from Health Watch would just like a word.
It's just a point of information for everybody on the work plan topics that are coming up. So Health Watch, as people will know, works with the community and patients. We have a showcase event coming up on the 12th of October at Mansfield Library. And in that event, we'll be looking at a major report we've done on dentistry in the city and county. And that will be also joined up with the Health Watch England's reports on dentistry, which is directly into NHS England. So that would be a useful thing before our meeting.
Yeah.
The second point we're doing is GPs and access to GPs, which has been very relevant this morning. So if that's okay with you, Chair, I'd like to be able to send all the link. You will probably get an invite anyway, but if I could put a link in the minutes to
Please
the
do.
event. You can also, if you can't make Mansfield Library, you can then watch the event online afterwards. We're not going to broadcast it, we're going to record it and then have it on the website. Those reports as well will also be available on the website, and maybe if I can give a link to the reports for those
Yes,
Scrutiny
please
so
do,
that
to
you've got
Noel,
them.
and Noel will forward
They're
it.
very relevant to Nottinghamshire dentistry and GP
I think
access.
all members would be interested in that. Thank you, Sarah. Thank you for that. Thank you, members. Thank you, officers. And thank you to the visitors.
Thank you all very much.
Right. Pardon? Oh, we might invite you back again. Well, they're looking for somebody on this committee now. Oh, you're on it?
No, I've already offered it.
Oh,
the thing
you-
is, it'll depend on the by-election form, what it is.
Oh, yeah.
If that happens with the district, they put me on planning, that takes me off the next week.
Right, well, it always runs a bit late.